2, 1. We are live.
A very good evening to all of you and all the delegates who have joined today. Welcome to today's online symposium, Way Forward in Clinical Nutrition, an Indo-British collaboration which is being organized by NOLEAD in association with two leading nutrition-based associations in the world, BDA, which is the British Dietetic Association, and IDA, Indian Dietetic Association. The vision of NOLEAD is to bring the best in health education accessible to you right from the comfort of your homes. Learning never stops in healthcare, and there is a blast of information all around you. But which information is right and evidence based, and which information can be trusted? This is what NOLEAD strives to segregate. Knowledge leads, NOLEAD. And this is why and how we bring the right information from the experts in their field. And this is all NOLEAD is all about. Now, the importance of nutrition management cannot be overlooked in today's scenario. With the lifestyle disorders taking the pandemic proportions, with the newer insights in genetics of disorders, with a better understanding of epigenetic phenomena, nutrition therapy is something all the healthcare professionals need to understand. And all this becomes more relevant for the budding nutritionists who are just entering into the field. Clinical nutrition is a complex subject, and understanding the intricacies of the clinical nutrition requires the right type of guidance. There are challenges one face on the way to learn, and these challenges only grow when you face a patient who asks for your help in the clinics. To help you understand those intricacies and those challenges, today we bring to you a series of lectures that would be spread over 2 days to help you understand what clinical nutrition is all about. I have with myself in the managing committee Ms. Najia Qureshi and Ms. Anuja Agarwal, who are the leading nutrition experts in Britain and India, respectively. Let me introduce both of them. I hope my slides are visible. Najia is a registered dietitian. She has done her master's in nutrition. She is the director of education and practice and policy. She manages the education and professional practice team, and she is responsible for all the strategic development and the management of the education and professional practices functions of the BDA. She has oversight of all education and professional, just give me a second, professional practice. She oversees the research work and the workforce development work streams, and she directs the strategy and provides advice and support to the BDA board of directors. She leads on the professional committee, and she also works as a clinical dietitian. And she was very much of a clinical nutritionist before coming to BDA. Along with Najia, we have Sian Cunningham and we have Fiona Audley, who would be delivering the lectures on the clinical nutrition practices. From India, we have the senior-most nutritionist who was recently judged as the best nutritionist in India, Ms. Anuja Agarwal. She is the recipient of prestigious R&D Sadhana Award of 2022 in clinical nutrition. She has also received award in excellence in clinical nutrition in 2022-23, and her academic achievements have been tremendous. She has 34 years of experience in pediatric nutrition, and anybody who's who has anything to do with clinical nutrition knows Ms. Anuja Agarwal. She has, to her credit, fellowship in pediatric nutrition from Birmingham Children's Hospital. She's a certified genetic metabolic dietitian, and she's also certified in dietary therapies in epilepsy and autism. The list goes on and on. Her areas of special interest to her are juvenile diabetes, dietary therapies in epilepsy, dietetic therapies in genetic disorders, and pediatric gastroenterological disorders. She is a member of CII, which is the National Committee of Nutrition. She is also on the scientific panel member of SSAI, And she was also faculty in the NEST initiative and Ministry of Tribal Affairs and PHFI. She is the National Vice President of Indian Dietetic Association. And apart from that, she has written a number of books. She has authored nutrition chapters in Essentials of Pediatrics, which is a well-known textbook for MBBS students. She has a number of publications in national and international journals with high impact factor. I welcome both of you to the platform and today's online symposium. I also invite you to say a few words. First of all, Nadia, I would like to hand over the platform to you. And what are the challenges and in a clinical nutritionist faces in the today's scenario, and how can they overcome? Please.
Good evening, everybody over there. It's good afternoon here, but evening to you. So welcome, everybody. Thank you for giving up an evening of your time. I know this is your personal time, probably after work. I hope you've had a chance to have something to eat and maybe some chai as well. But it's really lovely to join you. It's an honor to be asked by the team in India to help pull this program together. I don't know what we can share with you. You're experts in your own fields as well, but it's really nice to join you. I'm hoping over the next couple of days, today and tomorrow's sessions, that we can. I've just shared my slides. After all that, at the beginning we tested all our slides, and I haven't even shared my screen yet. So let me do that first of all. Is that sharing?
Yes.
Yeah. Okay. So yes. So over the next couple of days, I'm hoping that we can learn from each other, celebrate our diversity. Actually, we may do things differently. I think our challenges are the same. I think you'll find as we go through the sessions that a lot of the challenges are the same, but how we may approach them may be different. So it's about celebrating that diversity and validating what we already know is good science. So if we find that you think, oh my goodness, that we're doing things very differently, there's something very wrong, because the science, the world science of nutrition, hopefully we're all as dietetic profession and medical professionals are using the good science, I'd like to call it, evidence-based, and that we are using that science just differently in each country. Before we move on to the context, I think we can't do anything without mentioning the pandemic. I think we can all maybe remember the day that we were told to go home, close the doors, stay away from each other, wear masks, all those things that seem so alien. And I still can't believe the images and the sounds of the deserted streets and silent cities around the world. It is quite, it's hard to believe that it ever happened. But when we emerged from the pandemic, however, the world did not return to business as usual. COVID really changed the way we practice healthcare forever. So it was a new world we were looking at. The healthcare burden was strained before COVID. I mean, you had diabetes, obesity, cancer, all of these things that the World Health Organization has listed as the main areas of ill health around the world. There won't be any surprise to you, cardiovascular disease, COPD, stroke, kidney disease, the neonatal conditions, and Alzheimer's. The list is there for you to see, and it won't be a surprise to you. But after COVID, things changed a little bit. It wasn't that these conditions went away, they were there as well, but perhaps they were magnified. There was a lot of organ damage following COVID, and we're beginning to see the different areas that this is showing itself. So heart, kidneys, and skin were identified as key areas where long COVID was showing its facets. Fatigue, headaches, dizziness, all of those things started getting reported. Mental ill health is one of the things in the UK, certainly, that has really been magnified after COVID, after shutting down for for months on end. I think that became something that really came to the fore. So tackling the pandemic of mental ill health is something that's quite serious. Malnutrition from a different point of view. So we had economic problems, I think, around the world. Certainly for the UK, we have, I think we perhaps, avoided recession in its true sense, but we had huge problems with financial difficulties. The cost of everything, cost of living went up really quickly, and people were unable to keep up with that. And people were making those choices, particularly during winter. Do we heat the home or do we eat food? So, families going without food so they can eat, feed their children. People losing their homes because they could no longer afford to live in their home were made homeless. So we have a huge amount of work to do around malnutrition. We have an aging population that was there before, but we have that still today. And now we have the added burden of whole areas of where people have come from, war-torn areas, so refugees have joined it, and they have their own health problems. So there's a lot that's changed in the world post-pandemic. But what do we need? What do all of those what do the population, all of our populations need? Certainly in the UK, our populations, our patients are calling for care closer to home. They want easy access 24/7, all around the clock. We want our care when we need it. We want patient-centered care. So we want it to be about us. We don't just want, generally with patients, we want this. No, we want the care that's required for us. We want follow-up and ongoing support. We don't just want the one time, here's what you do, and then you never see a healthcare professional. They need support with these conditions. We need to be, our patients want appropriate care. So we want to be able to give care that is appropriate to them, considering all their EDI, equality, diversity, inclusion characteristics, whether they're disabled, from a different community, different religion, doesn't matter what shape or size, it must be identifiable that the healthcare providing is for them. They want a one-stop shop. They don't want to go to, 10 different places for the different care. They want all the care in one place. And most of all, they want to be able to trust their healthcare professional, that healthcare professional is providing the care that they need, that is based on the best evidence, and that it's not going to do them harm. The trust is really massive. But what the challenges then is for the healthcare systems? How can we deliver all of that? We've got an aging healthcare facilities where we've got to build new facilities that are high tech and all the rest of it. We want to build them closer to home, or at least have populations that can have easy access to clinics without having to go to the main hospital. We've got a fragile workforce. They're not all, the numbers are, sort of a challenge for the whole workforce, not just for doctors, nurses, dietitians, and all AHPs. The healthcare workforce is fragile right now in terms of numbers. We've got the need for flexible working that increased during COVID. We changed it. Clinics were being done online and through Zoom, just in technology. So people want to be working from home. They want to be able to look after their families and as well as work. We've got a huge amount where other professions were made furlough and didn't do much work. As healthcare professionals, we've got burnout completely as people are coming through and the pandemic, but still haven't had a break. There's new science evolving all the time. So, this whole new area of post-COVID, we need to know, well, what is that all about? What does that mean for our practice? So emerging new science that we have to come to terms with. And for that, we need healthcare professionals that are trained, have education, that have all of those CPD opportunities that bring new science to them so that they can learn and be able to use that with their patient group. Amongst all of that, we've got, certainly in the UK, the fear of litigation, where every time anyone tries anything new, or you're stressed at any one time and something goes missing, or your practice is perhaps not quite the same as it would do if you had the time that you needed with each patient, there's always that background fear of litigation and patients saying, well, hang on a second, you're accountable. But we are accountable. As regulated healthcare professionals, we are accountable. So that's in the background. And equally, I've also put research funding. Certainly for us, we're finding it ever more difficult to find funding for research, or the people that have got the money, which is industry, have the money, they're prepared to give it for research funding, but then we don't trust that. We don't trust that funding, that it's not going to be biased, or that healthcare professionals will be, of course they will say that, but because they're funded by a certain industry. So research funding is dwindling, and yet we need more research. We need that science base to be able to move on and develop our practice. So what have we got? We've got workforce planning issues. We want that the population needs the right people, right skills, right place, right time, and at the right cost. And that's proving a challenging and difficult thing to land. So we need to attract the workforce in the first place. We need to motivate them with the right salary scales. We need to engage them. So we want more, engaging roles in what we're doing. We want to develop people, train people. That will lead on to people being retained, not wanting to leave, and keep attrition low from these professions. And then we get high-performing professionals. That's a tall order, and that's what we're grappling with in the UK at the moment. But no profession can do it on its own. What we are moving to, and what we have seemed to be making ways in, is in that teamwork, that all professions are pulling together rather than saying, this is my bit. I'm a dietitian, so this is my bit. I'm a doctor, so this is my bit. And this is about pulling together. And finally, I just wanted to say that we have all got a role to play. Doctors, pharmacists, support workers, nurses have all got their place. Dietitians, doctors, nurses, in that middle bit when patients are getting more, the condition is getting more serious or complex. And then finally, we have dietitians in nutrition care who are practicing at the top end of their license, prescribing drugs, putting in tubes, undertaking endoscopy, all of the things that perhaps were the realm of only doctors. Now we're expanding, we're all doing that. Everyone's shifting to practice at the top end of their license. That's me, an introduction to the context in the UK. I hope that was useful. I don't think you'll find there's any surprises there probably, but I'll hand you back to Sweta to move on to.
Thank you so much, Nadia, for sharing the challenges that you face in Britain. I think the challenges in India are the same. I invite Ms. Anuja Agarwala, ma'am. I think she's there. Ma'am, please unmute yourself.
Yes, I'm there.
I would like to share your, I would ask you to please share your perspective about what are the challenges then the clinical nutrition faces in India.
Yeah, I'm sorry, I'm not able to open my camera anymore. Can you hear me?
Yes, ma'am, we can hear you.
Just a sec. Give me a second. Yeah, no, it's not opening my video. So, now probably, yeah. So I've not made my slides for this, and I'm so happy to be connected with British Dietetic Association and a very unique bond which is being organized by No Lead. Yeah, our challenges are very much same and clinical nutrition, but more I will talk about this when in my last lecture when I discuss more about our regulations in that is because I'm only presenting, it'll be a bit of an overlap. So clinical nutrition, as we know, that it is a lot to do with metabolism and people have to understand metabolism. So our curriculums in India are a little bit of, there's a lot of heterogeneity in our curriculums. There's a lot of heterogeneity in our trainings, programs and all. And that's why what we say about clinical nutrition, the assessments at the hospital level becomes very, very important. Those assessment criteria differ from hospital to hospital. So it is not a structured kind of a protocol that we follow in all the hospitals and clinics and all. It is because it starts from the heterogeneity in the curriculum and it leads us to that. But a lot of our senior dietitians are doing very good work in clinical nutrition by virtue of their experience within the hospital, and they have developed their own protocols in clinical nutrition. So they are doing nutritional assessment in terms of, A, B, C, D, anthropometry, biochemistry, clinical history, as well as, monitoring, follow-ups, and also, necessary interventions by understanding the diagnosis, diet, and disease relationships and link between it. So, and also a lot of trainings. Our trainings, in fact, have improved over the years as we have established our RD board is really become very active. And there's an initiative called Ujjwal, which means what does it mean? It means shine. Yeah, Ujjwal. So under that, a lot of our students get trained through online mode and to appear for the RD exam. So this is a bit of a synthesization which they receive and in a structured form which they received in the clinical nutrition aspects. So I would just say whatever Nadia has presented, our challenges are the same, but still we have to structure our curriculum. We have to structure our training programs. We have to also structure the way we work in the hospitals, the intake charts, starting from intake charts and how we monitor the monitoring charts. All these things need to be structured, and we are at it because our Allied Health Profession Council has just been just been commissioned through the Parliament Act in India. So it is working on that criteria, starting from the curriculums. So I would not say much about it because I wouldn't have much to say about clinical nutrition. It is on the rise, but we have to, of course, we have to work a lot in clinical nutrition space. Yeah.
Thank you so much, ma'am. I am sure with the stalwarts like you working in this field and educating all the budding nutritionists, we will reach there. And with this, we go on to the first talk of the evening. It is an overview of dietetics in the United Kingdom. The talk would be given by Fiona Audley. I think you're there, Fiona.
Yes, thank you, Sweta. Naja, are you going to share my slides? Is that okay?
Yes. So I would like to share the Fiona's CV once for a minute. Let me introduce Fiona. She plays a lead role in the development of dietetic practice. She provides direction, advice, and guidance for the membership and inputting into national strategies across the UK on issues that impact dietetic workforce development. She leads the projects and programs of work that push the boundaries of dietetics and supports on all the members in their day-to-day practice. And she also has a background in sports and exercise nutrition, and she has been working as clinical dietitian before coming to British Dietetic Association. Over to you, Fiona.
Thank you very much. Naja, are you able to share my first set of slides? Thank you. Okay. Okay, so firstly, just to say good evening and thank you for joining us today, and thank you for having me here to speak. So over the next 20 minutes or so, I am hoping to give you an overview of dietetics in the UK. And this is quite a broad picture. It's what we do, it's how we're set up. So a couple of the things we're going to talk about are the dietetic workforce. Sorry, Naj, next slide, please. So as an overview, we're going to look at the dietetic workforce in the UK. We're going to look at UK registered dietitians and what that means. We're going to look at our levels of practice, our 4 pillars of practice, the practice settings that UK dietitians work in. We'll touch on our scope of practice. And then in the latter half, I'm going to look at our model and process within the UK, which is slightly different to the nutrition and care process. Next slide, please, Naj. Okay, so the first thing I wanted to do was to provide a picture of what makes up the UK dietetic workforce. And I wanted to touch on this slightly to highlight that the dietetic care is not solely provided by registered dietitians. So in the UK, our workforce is made up of unregistered and registered dietetic professionals. And on the slide here, you can see that we have 7 roles, which are separated by the red dotted line. So the roles to the left-hand side depict members of our unregistered workforce, and we also call this group the dietetic support workforce. And these are defined as individuals that work for dietetic services, but they're not regulated by the health and care profession or the HCPC. So they work alongside us as alongside registered dietitians, and they deliver service user and client care, and they work under a range of supervisory arrangements under agreed guidelines and protocols, and they're part of MDTs, so multidisciplinary teams. They're under supervision, but they also work with individual dietitians or autonomously within the scope of their role. So the education, experience, and knowledge and skills of the support workforce progress as you move through the 3 levels. And they are integral to the dietetic profession. Now, on the right-hand side of the dotted line, we do have the registered dietitians. And as you can see, these are depicted across 4 levels of practice. And over the next few slides, I'm going to provide more information on this area of our workforce. Next slide, please, Naja. Okay, so the reason that we have such a clear distinction between the support workforce and registered dietitians is because the title of dietitian is legally protected. And that means that only those who have received registered status can call themselves a dietitian in the UK. To use the title, you have to be registered with the Health and Care Professions Council, or the HCPC for short. And we're the only UK regulated nutritional professionals within the UK. Now, by registering and continuing to be registered, dietitians are agreeing to abide by the HCPC standards. I'm not going to go into this in a huge amount of detail because I know that Sian is later going to talk about this within her presentation, but in a lot more detail. At present, within the UK, we have around 11,000 registered dietitians, and we are always working to increase this number. Next slide, please, Naj. So as I mentioned on the very first slide, we have 4 levels of practice for dietitians, and these include entry level, enhanced, advanced, and consultant, as shown on the slide here. These levels progress alongside the education, knowledge, skills, and experience of dietitians. Full descriptions of each of these can be found in our BDA post-registration professional development framework, which is available on our Dietetic Journey webpage. Just touching on these briefly, though, we have the entry level at the far left, and this is where dietitians enter the profession. So they're often also considered newly graduated, and their scope will be limited at this point, but over time, with support, it will extend. Complex and unfamiliar situations are managed with supervision and measured planning, and they are often supported at this level via preceptorship programme. At the next level, we have enhanced, and this is when a dietitian is considered to be a specialist. And in many instances, a dietitian may be working in 1 or 2 particular areas or specialisms. They work without direct supervision, and they adapt their knowledge and skills to specialist or novel roles and situations where there is increased levels of complexity and risk. We then have advanced, and these dietitians have an authoritative knowledge of their area of practice and associated disciplines, where excellence of practice is achieved with ease. They often work within 1 particular specialism or area, and they'll be operating at a master's level. Now, finally, the consultant level of practice. This is where dietitians will be recognised as a national and international leader in their field. And this is both internally and externally from the profession. They may have a doctoral qualification in a subject relevant to their scope of practice, and it's all about innovating and leading the development of new techniques, ideas, and approaches, and evaluating and disseminating these to advance practice in their field. Next slide, please, Naj. So the dietetic profession across all levels is underpinned by the 4 pillars of practice. So these are shown on the slide here. So we've got practice, we've got evidence-based practice and research, we've got facilitated learning, and we've got leadership. And the premise is that the development of level appropriate skills in all four of these areas will produce a well-rounded professional. Now, the practice pillar shown in orange accounts for the wide range of settings that dietitians work in. It focuses on practicing and working safely within the scope of practice and providing services that are respectful of service user preferences and providing appropriate communication. The evidence-based practice and research pillar shown in green focuses on the use of best available research and evidence, collecting, analysing and communicating data on outcomes and continually aiming to improve the quality of service provided. The facilitated learning pillar in blue there focuses on developing resources and sharing knowledge to improve the knowledge and skills of others, including resources to support service delivery, assuring and developing their own and other skills, and maintaining fitness to practice. And then finally, the pillar in purple is leadership, and this focuses on contributing to organisational strategy, managing change, contributing to advocacy efforts related to health and nutrition, and assuring quality of service. Now, the capabilities of these 4 pillars for each level of practice are found within the post-registration professional development framework, and this framework supports dietitians to develop and progress their career. Next slide, please, Naj. So within the UK, dietitians work within a variety of settings, including health care services, both public and private, food services, education, sports, research, industry, freelance and media. They can also be found in charities, government organisations and prisons. Whilst the majority of dietitians do still work within the clinical healthcare services, predominantly within the National Health Service or the NHS, as the importance of nutrition and dietetics and the value of the dietetic workforce is being recognised, the settings in which dietitians are found are expanding and evolving. Next slide, please, Naja. So within the UK, we have broadly defined the scope of practice, which is included on the slide here. And we outline this to be the use of nutrition science and evidence to assess nutritional needs, diagnose nutritional problems, and undertake a range of activities and interventions to enable, enhance, or influence the diet and nutrition of individuals, groups, populations, and services. A cornerstone to our work is about being evidence-based, as we saw in the pillars, and this is in which we're using activities or interventions undertaken which are linked to existing or emerging occupational practice frameworks, and they're acknowledged by the profession and supported by a robust body of evidence. Defining this has been important to us, firstly because whilst we are the only regulated nutrition professionals within the UK, we're not the only nutrition professionals in the UK. And so this supports stakeholders' understanding of what we do. Secondly, it supports dietitians to determine if their activities fit within the scope of dietetics. And this is of particular importance as roles begin to expand and progress. And one of the reasons I've included it at this point in the presentation is because it helps to introduce the final element that I want to focus on, which is going to be the BDA model and process for nutrition and dietetic practice. So the model and process guides dietitians through the process of assessing nutritional needs, diagnosing nutritional problems, and undertaking interventions to enable, enhance, or influence diet. As the fundamental elements within the scope, it places the model and process as the backbone to clinical dietetic practice in the UK. Next slide, please, Naj. So the model and process for nutrition and dietetic practice, or the model and process as we call it for short, it supports those key steps of assessing, diagnosing, and then intervening. It was influenced by the nutrition and care process and model developed by the American Academy of Nutrition and Dietetics. And it describes the consistent process UK dietitians follow in any intervention or episode of care, whether that's with individuals, groups, or population, or in clinical settings, public health, or health promotion. And as you can see on the slide here, the model is shown itself, and you can see that it consists of 6 steps. So we've got the assessment, nutrition and dietetic diagnosis, strategy, implementation, monitoring and review, and evaluation. And it demonstrates how dietitians integrate professional knowledge and skills into evidence-based critical reasoned decision-making. It facilitates autonomy, outcome data collection to allow dietitians to evidence their contribution to care and to promote service development and improvement, and also a standardized template for record keeping. You can see that at the very centre of the model is this focus on the service user, and this illustrates that the service user is at the centre of all dietetic practice. So that means providing care that is respectful of and responsive to individual service user preferences, needs and values, and ensuring that their values guide all of our clinical decisions. At the very top of the module, you will see that we have the identification of nutritional need. So this will occur following screening or a referral by a healthcare professional or a self-referral or similar. And this sits outside the modelling process, but once we receive that, it initiates the start of the modelling process. And over the next few slides, I'm going to go through each step in turn. So next slide, please. So the first step in the model is the assessment. So as the name suggests, we're going to be assessing the individual or the group or the population. And we're doing that by identifying, collecting, analysing and interpreting all of the relevant information. And we're doing this using critical reasoning. Applying critical reasoning and knowledge to this information allows us to analyse that data, to prioritise its importance, establish nutritional status, find any patterns or relationships, and evidence the problem clearly and succinctly. Now, the specific information available at this stage will vary depending on the cases and the practice settings. And what you collect will also vary depending on the service user's health needs and expectations, their conditions, the reason for referral, but also from what is available in terms of practice-based evidence and guideline perspectives. So if we just think about assessing an individual service user, the sort of information you'd be looking for or you might want to access is the referral information. You might want to think about the lab results, the results from medical procedures, MDT records, food and fluid charts, a range of different items. So that's certainly not a full list there. And the information can roughly fit into the 6 different categories. And we've got them on here. So anthropometry, biochemistry, clinical, dietary, environmental, behavioural, social, and then functional ability. And all of this information supports us in the next step of the modelling process. And next slide, please. So within the diagnosis step, the evidence from the assessment step will be used to determine our nutrition and dietetic diagnosis. And this NDD may reflect an existing problem, a potential nutritional problem, or a preventative or anticipatory care. So when a nutritional intervention has the potential to maximise health and prevent or manage a deterioration in health. Now, the PAS statement, I know it's called a PES statement, I think, in the nutrition care process. We call it PAS, and it helps us to formulate the nutrition and dietetic diagnosis. It stands for problems, etiology, signs and symptoms. So the problems relates to the key nutrition related problem to be addressed in that dietetic intervention. And it's really important at this stage that that problem relates to nutrition and that it's within the scope of dietetic influence. So if we can't influence the problem, then we then need to refer them on to a healthcare professional who can support. We've then got etiology, so the causes of the nutrition related problem. And this really needs to be the root cause. This is also usually within the scope of dietetic practice and should be supported by the data collected during the assessment process. We then have the signs and symptoms, so a cluster of evidence to support that the nutritional problem exists. So the signs and symptoms can be used as outcome indicators to measure the effectiveness of the intervention. They might be in the realms of biochemistry or anthropometry, and they need to be monitorable so that you can reassess them during or after the intervention to evaluate and document any related improvements. So just to reiterate, the PAS statement clearly states the nutrition related problem that we as the dietitian are responsible for taking action on, what has caused it and the related signs and symptoms. We use the connecting phrases of related to and as evidenced by to bring the different components from the PAS statement together. And UK dietitians are increasingly using digital records, enabling them to have more easily enabling them to more easily record their interventions and outcomes in a standardised way. This facilitates data analysis, audit and research to promote service review and development. The UK currently uses SNOMED CT standardised clinical terminology. Next slide, please. So at this next stage, so we've got our nutrition and dietetic diagnosis, we're now at the strategy stage. And at this point, this broadly outlines what you or we as the dietitian and the service user jointly want to achieve, the indicators that will be used to measure this, and how you're going to actually achieve it. So we can look at this in more detail by looking at the different components that comprise the strategy. So we've got the proposed dietetic outcome, and this is what you're aiming to achieve by the end of the episode of care. So this is your overall aim. It's an agreed outcome based on the dietetic problem identified in the diagnosis. It will be the actual change that you want to see. We then have the proposed dietetic goals. So these are small, smart, so specific, measurable, achievable, realistic, and time-bound goals that you both want to achieve by the next consultation. And these are much more specific and short-term than our overall outcome, but they do need to relate to this. So goals may relate to lifestyle modifications, changes to the food environment, dietary supplements, behaviour change, and so on and so forth. We then have the outcome and goal indicators, which will be used to measure the change and can be compared against reference standards or a baseline. At least one indicator is chosen for each of our dietetic outcomes and each goal. An example might be things like knowledge scores, confidence scores, or weight. And you may very well have similar indicators for both the proposed outcomes and the proposed goals. The next element is the intervention category, and the proposed dietetic outcome and goals addresses the nutrition and dietetic problem through an appropriate agreed dietetic intervention. In this section, we're describing the type of intervention that will be used. So different types of interventions are grouped together into categories, such as knowledge building, specialised diet, behaviour change. The broad categorisation of interventions enables them to be recorded and evaluated at a specialty, service and national levels. Finally, we've got the proposed actions, and these are the actual activities that will be undertaken to meet the dietetic goals. So they need to be evidence-based and reflect best practice. The proposed actions may be carried out or coordinated by the dietitian, but it could be by the service user, it could be by carers, it could be another member of the care team. And like goals, actions need to be smart. So they need to follow the SMART principle. And the actions together with the dietetic goals will be reviewed and changed as required at each consultation until the outcome is met. Next slide, please. So step 4 in the modelling process is implementation. And so during this stage, we're considering the information resources, communication and motivational skills, the coordination, the leadership and the management needed to effectively implement the proposed actions that will ultimately deliver the strategy. So in essence, how are we actually going to make our actions happen? So it's the dietitian's responsibility to coordinate that implementation stage. We're deciding who is responsible and therefore who will manage each of these proposed actions. And all of the roles and responsibilities should be clearly documented, as well as the length, frequency and duration of the intervention and any review dates. And the purpose of this stage is to actually positively influence the nutrition-related behaviours, the risk factors, the environmental factors, or aspects of physical or psychological health or nutritional status. Next slide, please. The 5th step in our model is the monitoring and review. And just as it sounds, so at this stage, we're measuring progress towards those outcomes and those goals, and we're using the specified indicators identified in the strategy stage. And this will be done at planned intervals, and we would have defined that in the implementation. And it's important at this point to consider and reflect on the barriers and facilitators to progress. So at this point, there are several potential outcomes which will determine whether you stay at this stage, whether you follow the arrow to stage 6, which will be evaluation, or do you return to stage 1 and are you reassessing? So it could be that the dietetic intervention is appropriate and a further appointment is made to review again at a later date, and they continue to working towards those goals. It might be they revisit the nutrition and dietetic diagnosis due to a change in priorities, and this would likely lead to a change in agreed actions, outcomes, goals, and implementation. And then at the same time, do you progress to the end of the episode of care and do you discharge the service user? So any decision at this point is done in partnership with the service user. Next slide, please. So the final stage is stage 6, and this represents the end of the dietetic intervention, or the end of the episode of care. And at this point, you're establishing whether the proposed outcomes have been met, and has the problem within the diagnosis been resolved or improved. And we can again use the outcome indicators at this point to measure this change. And ultimately, the answer will either be yes, it's been met, or no, the outcomes have not been met. Whether they are met or not, this is an opportunity for all parties involved to evaluate the progress that's been made, communicate any variances from the expected outcomes, determine the factors that may have helped or hindered progress, identify any research gaps, and share learning. And this is really important both as a dietitian to support your development, but also to support with service development and improvement in the future. Now, there was only time during this session to provide an overview of the modelling process, but I appreciate that seeing a case study or example of this used in this way would have been a useful addition. Whilst I couldn't cover that today, you can access the BDA modelling process on our modelling process for dietetic practice webpage. And within the document, there is a full example of this being used. Next slide, please. And this is the final slide, I think. And then finally, just to provide some supporting resources that you might find useful. So practice-based evidence in nutrition. So this is almost like the Google of nutrition. And it's a database that provides evidence-based answers to practice questions. And they've got really useful practice guidance toolkits that provide examples of assessment, past statements, and nutrition and dietetic diagnosis for a range of clinical conditions. And they do use the nutrition and care process. So they outline everything, all the steps that you want to consider. And for each clinical condition, they tailor it to this. There's the post-registration framework that I mentioned if you want to have a look at the different roles and the different levels of practice. There's the modelling process itself, and then I've also included a link to the Health and Care Professions Council. And the next slide is a thank you. Thank you very much.
Thank you so much, Fiona, for introducing us to the British dietetic practices and processes. It is a beautiful structure, and structure definitely gives more stability to the practice in the longer run. And especially, I've gone through the PEN, which is the evidence-based nutrition, just like it is evidence-based clinical practice and medicine. The PEN is a beautiful website, which I feel is useful for all the healthcare professionals. It might be a doctor or it might be a nutritionist. It is useful for all of us to what to recommend and what not to recommend. Moving forward to our next talk. Our next talk is on nutrition care processes and what are the challenges and opportunities in India. And Ms. Charu Dua, I'll just share her resume slide. Ms. Charu Dua is a senior nutritionist and she's a diabetic educator in Amrita Hospital, Faridabad. She's a senior member of Indian Dietetic Association with over 28 plus years of experience. She is a FODMAP diet trained nutritionist and from Monash University, Australia. And at present, she is also an avid academician, and she's teaching the Bachelor's of Science nursing students and also been teaching the nutrition students. She's also practicing at present as she's training on the nutrition care processes, and she's an elect executive member IDEA Delhi chapter. She's also an NABH external assessor from Quality Council of India. She's on board of as KOL on Healthcare Sector Skill Council. She's formerly regional head clinical nutrition and F&B Max Healthcare. She's been working on different esteemed hospitals throughout Delhi NCR. Her major achievements also includes Best Speaker Award in different CMEs. And has also got a GEM Award for for the performance of the quarter in 2016 and 17. And she also got the Quality Award for good performance in NABH audits, and she has been consistent through it. She has authored a book for CBSE. CBSE is the main curriculum that is followed in schools in India. And she has trained over 500 budding nutritionists and F&B interns. With this, I hand over the platform to you, Ms. Charu.
Thank you, Dr. Shweta, for a nice elaborated introduction. At the outset, I would like to thank Indian Dietetic Association, Anuja ma'am, and No Lead, Dr. Shweta, and British Dietetic Association to give me this platform to share my view on the topic. Are my slides visible?
Yes, your slides are visible.
All right, great. So my work actually has been done by the previous speaker, because nutrition care process whichever the country, the steps almost remains the same. But I would like to talk about a brief about my journey when how does the nutrition care process started. I remember 2004 when I was working for a private institute, Max Healthcare. We went for NABH accreditation, and that's where the hospital authorities and the accreditation associations wanted us to document our nutrition assessment. And before that, no hospital in India was documenting nutrition assessment. And that's where the journey of documenting nutrition assessment began. I'm talking 2004. And then followed by JCI coming in India, and documentation continued to get robust. But every individual has made their own document. It is a hospital-based practice and a advanced or a consultant level dietitian who has made this process. But when it comes to an entry-level dietitian or the beginners, or maybe even a mediocre level dietitians, they don't understand what exactly in-depth nutrition care process is. And assessments are just papers which doctors are not even visiting. Only when it is a consultant level dietitian or an advanced level dietitian, they have a view. In India, I may not be wrong in saying more than 70% of the hospitals in India do not have a EHR or HIS. It's a handful of hospitals which have complete EHR and HIS, including the nutrition model. And again, this nutrition care process is not standardized. As I told, everybody is having a practice. So let's see how we can begin our journey. I was introduced to nutrition care process in 2010 when I participated in a DINC study with American Dietetic Association. And then now I am attending a formal course with them, and I shall be doing a pilot in Amrita Hospital along with Pakistan dietitians and Philippines dietitians. So let's see how are we going to go about it. So I would like to give you a disclaimer that this presentation utilizes the NCP model developed by Academy of Nutrition Dietetics. While the core principles and structures of NCP are universally applicable, the examples and the case studies provided in this presentation will help the dietitian in India to consider the robust documentation of NCP related to Indian context. The ADA NCP model is acknowledged as a foundational framework guiding this adaptation. My slides are not changing. How do I change my slides? My slides are not, yeah. Okay, so the objective of my presentation is to understand the components of nutrition care process. I will be skipping a lot of slides because the former presenter had already presented. Learn how to implement NCP in our clinical practices, explore case studies for hands-on experience, and discuss the benefits and challenges of NCP in Indian scenario. We have seen ADA recommends a 4-step nutrition care process. It is a framework which is given to a dietitian to practice and have critical thinking. It does not intend to standardize the nutrition care of patients, but it established to standardize the process. And a 4-step. So assessment definitely is for collecting the data, including various tools, and reassessment is for the purpose to determine whatever the data has been collected or the nutritional problem or diagnosis that has been identified, has it been resolved or not resolved. It has categorized 6 domains in nutrition assessment, and each domain has subclass into it, and each has a terminology attached to it. I would like to share my another screen and show it to you. Is this screen visible now? No, this is a wrong screen that I have shared. Is this screen visible? Is there some screen visible of mine?
Yes, it was.
Okay, let me see, where has it gone? Yeah. Is this visible?
Yes.
Yeah. So see, if you see each term has a terminology attached into it. So when I talk about assessment, all assessment has different domains, and in different domains, there is a list of terminology which a dietitian has to use. So they have standardized the terminology. The dietitian cannot use a terminology which she decides. In India, we are using the terminology that we are deciding. We don't have a standardized model. Right? So each category has it. I can't make you go through it. It is just a glimpse that I wanted to give it to you. I'll go back and start sharing my slides again. All right. Is it visible? My slides are back again visible?
Yes, your slides
Yeah.
are visible.
Great. Right? So each domain has a different category. That is what I have been explaining, and I will be quickly moving on to it. What is emphasized is to have a comparative standard. ADA is emphasizing the comparative standard, and VDA also is doing that using the RDA of your own country, using and practicing the evidence-based guidelines, and establishing the goal with the patient, which is measurable, and the progress of the nutritional status can be checked. So let's do a hands-on to a case. A 67-year-old male with medical diagnosis of congested heart failure presenting with dyspnea is referred to an outpatient to a dietitian post-discharge. This is his first visit to a dietitian. He is a retired engineer, lives alone, and has a weight of around about 61.3 kgs and has lost around about 3 kgs in over past 2 years. A 24-hour diet recall when taken explains that he eats only 1,200 calories and consumes frozen meals, processed meals. The cook comes once in a week and eats only 2 meals per day. His estimated fluid intake approximately is 2 liters a day. The nutrition-focused physical exam finding says ankle edema, he is on statins, and his sodium is 146 milliequivalents, potassium 3.6, and BUN is 14 milliequivalents. So now when we need to document again as an indicator. So a 1,200 calorie diet, this is the fluid. He consumes frozen meals and processed meals. In India, what we do, we understand, we listen, but we are not able to document. And why documentation is important? Because assessment documentation will lead you to identify the nutritional diagnosis. Hence, documenting in detail. Some of you may be documenting it, but 100% documentation by your team members. Ask yourself a question. Anthropometric measures, yes, we document. Biochemical parameters, yes, we all document. And when it comes to physical focus and findings, we see, we observe, but are we documenting? Is there a category? Is there a place in our prescription where we are writing this? Please answer yourself these questions. And in physical findings, there are many more indicators that you can think upon depending upon the disease. The patient history, yes, we definitely document, right? But are we documenting vis-a-vis the comparative statement? Example, 1,200 calories versus the estimated calories of 1,600 calories. And how have we achieved the 1,600 calories? Using what calorie equation? Is it a Harris-Bendix? It is a Mifflin-Stiff-Jaw activity statement, or is it a 25 to 35 calorie per kg body weight? Are we doing a comparative standard? We say low sodium, but what is the milligram of sodium? Are we writing this in 100% of the sodium our prescriptions? And again, I'm talking about the entry level and the mediocre level dietitians needs a lot of training on this practice. The second step being nutritional diagnosis, as said by previous speaker, nutrition diagnosis is a diagnosis which the dietitian can help correct. It is not a diagnosis which a medical practitioner or anybody else is able to help. Like, for example, stroke. Can we do anything with stroke? For example, hypertension. Can we do anything to treat hypertension? Yes, we can treat lifestyle modification and the diet part. So the diagnosis has to be something which a nutritionist is able to do and involves a lot of critical thinkings. And you need to prioritize the problem and evaluate the etiology or the root cause that can be addressed with nutrition intervention, and select the signs and symptoms from assessment and data. Again, it has 3 domains, and each domain has subclasses and classes. And the nutrition diagnosis has to be communicated in a structured sentence like PES. And PES has to be clear, concise, specific, accurate to the etiology, and based on reliable and accurate nutrition assessment data. So you have to ask yourself a question: can the dietitian resolve or improve the patient nutritional diagnosis? Evaluate what has been used as etiology. Will measuring sign and symptoms indicate if the problem resolved or improved? So we need to be very, very specific. So an example of a correct test statement would be: inadequate energy intake related to decreased ability to consume sufficient energy secondary to chronic COPD, as evidenced by consuming less than 75% of estimated needs for 1 month, weight loss of 5% in 1 month, reported lack of appetite. When we write this as a problem statement and a patient reads this problem statement, he would connect with the dietitian and he would also want to correct this problem statement. Till the time we define the problem, we take the assessment and we directly go into the implementation state in many of the audits that I have done across the country when I go as an NABH auditor. So writing the nutritional diagnosis is very, very important. And believe me, while I was undergoing a course and I was given case studies, writing the PES was a difficult thing. You need to do a lot of, it's not very difficult, but you need to have critical thinking skills to it. Another example of a PES statement: limited access of food related to lack of financial resources or purchase sufficient quantity of appropriate healthful foods, and lack of knowledge regarding food assistant resources, as evidenced by reports of 1 meal per day, lack of resources for food, and no support system. Incorrect PES statement: excess carbohydrate intake related to 8.5% HbA1c, as evidenced by newly medical diagnosed of type 2 diabetes with incomplete knowledge regarding appropriate carbohydrate intake. Now, why I am calling this an incorrect PES statement? Because in etiology, if you see, it is 8.5% HbA1c. So HbA1c, why you have to ask and you have to go to the closest and the best root cause. So excess carbohydrate intake, okay, the HbA1c is 8.5. Why HbA1c is 8.5? Because excess carbohydrate intake. Why carbohydrate intake high? Because this patient may not have the knowledge regarding, he may have a knowledge or maybe a belief deficit or maybe an attitude deficit. So etiology for this patient can be excess carbohydrate intake related to knowledge deficit, newly diagnosed medical diagnosis, type 2 diabetes with HbA1c of 8.5. So you need to see what you are able to handle. The etiology and the signs and symptom is where your intervention strategies would be built in. So diagnosis is a link between assessment and a link into an intervention. So if your PES statement is not correct, your interventions, the best of the best intervention, may go haywire. You need to continue to check the diagnostic status value, whether it is a new diagnosis you're doing or if it is a follow-up consultation, the previous diagnosis, was it active, resolved, or discontinued. Now, going back to our same case, the PES statement for our case would be inadequate protein energy intake related to lack of appetite due to dyspnea, as evidenced by reported calorie intake of 400 calories less than estimated requirement, 5% weight loss in 2 months, congestive heart failure. excessive mineral intake, sodium, related to food and nutrition knowledge deficit, as evidenced by reported frequent intake of processed food and frozen food meals considering high amounts of sodium, congestive failure, dyspnea, sodium, and ankle edema. This is the level of documentation other countries are doing. And while I'm presenting you this, we need to start thinking. And we have begun in Amrita our journey to start piloting all of this in our case profiles, and we are making a nutrition care process model in our OPD setup. Then leading to the third step, nutrition intervention. It's, as I've already said, it is directed to etiology, and the intervention may sometimes be directed towards signs and symptoms when dietitian cannot impact the etiology. And it is driven by etiology. Again and again, we have been speaking about it. It has two phases, a planning phase and an implementation phase. In planning phase, you need to collaborate with the patient to identify the goals of intervention, prioritize the nutrition intervention based on patient's preferences, urgency, impact, and potential of the available resources. We need to write a nutrition prescription. And when it comes to implementing phase, it has to be an individualized plan, and we need to continue to collect data. It also has 5 domains into it, and 5 domains have classes and subclasses for documentation purpose. But a dietitian should ask herself, are the goals identified are SMART, specific, measurable, achievable, relevant, and time defined? It is very, very important. You need to do a weight loss, and you're telling 10 kgs of weight loss, and you're not giving a time frame to a patient. It is not a SMART goal. Weight loss, 2 kgs every month will become a SMART goal. Do the goals consider client's needs and value? Is the nutrition prescription written to achieve the client's goal? Is the intervention directed at changing the etiology of pest statement? Right? So in our case, we need to prioritize. So energy was not that a priority because the patient weight was fine, the BMI was fine. Sodium would take a priority. So we need to address the etiology of the patient, food and nutrition knowledge deficit, to plan the intervention that can lead to increase in the nutritional related knowledge and the signs and symptoms of sodium intake and levels. So in planning phase, to this patient, we will say increase energy and protein intake, decrease sodium intake during meals by next visit. We will recommend a general healthful diet with sodium of 2300 milligrams per day and fluid less than 2 liters per day, and modifications would be suggested. When it comes to implementation phase, we will give the education material that we directly give after doing the assessment. We will provide ideas. Whatever we are doing in our consultation would come into the implementation phase, but identifying the nutritional diagnosis will become very, very important, because you as a dietitian would know a congestive heart failure, sodium is very, very important, but we need to make the patient realize and be very objective and smart enough in writing the goals of the patient. The step 4 is nutritional monitoring and evaluation, which is used to determine and measure the amount of progress made for the nutrition intervention and whether the nutritional related goals, expected outcomes are being met. It is very, very important that in India, we keep cribbing that patients don't turn up for a follow-up. If our prescriptions and our communications are strong enough and we are defining the goals with the patient, and if we start following the nutrition care process, you will see that the junior dietitians and the entry-level dietitian follow-ups also increases. We have observed this in our hospital. Not only follow-ups for me or a senior dietitians are high, but nowadays we are getting follow-up for a junior dietitian by giving them a small framework to follow. Right? So the activities of the dietitians during the step 4 would be monitoring the progress, would be measuring the outcomes, and she will definitely be evaluating the outcomes. Right? So monitoring and evaluation terms has again 5 steps into it, and every 5 domain has different classes and subclasses into it. And ADA also talks about indicators and terms used to identify data elements that are evaluated to measure change based on nutrition intervention. The current patient data should be compared with your nutrition prescription, your RDAs, your DRIs, your country-specific guidelines for specific disease condition, institutional and regulatory standards. right? Every unit practice their own guidelines and their own regulatory standards. We don't have a specific guideline and pathways for dietetics practice in India. So during monitoring nutrition and evaluation, the dietitian monitors and evaluates the patient's progress through consistent terms or indicators against criteria selected by dietitian, and sets a stage for reassessment in the next cycle of nutrition care progress. So in our case, our monitoring and evaluation documentation would be, indicator would be sodium estimated in 24 hours, which is a food and history domain, and current reported intake of sodium higher than estimated need of 2300 milligrams per day. We will monitor the diet recall and labs at next week. This is the criteria for a follow-up that we are setting up, and we are giving a goal to a patient. Measured weight, patient weighs 135 pounds, will continue to monitor any weight change or gain or loss at next visit. Edema was an indicator, will monitor edema if present upon the next visit, and definitely dyspnea, will monitor dyspnea if present upon the next visit. Please focus on the nutrition domains. Every domain has to be written so that you are not missing out anything, and you're not missing anything that the patient should not be asking. My slides have stopped moving. I'll again share. I'll go to the slide. I'll have to, it's again and again stopping. I'm not able to see the slideshow icon. Yeah. It is not moving. My slides are not moving.
Charu, do you have many slides? Then you can just, say it, see your slides and.
Wait, I'll just say it. I will not do on a slide share model then. Is that okay?
Yeah, sure.
I think that's okay.
No, that's fine.
Let me try one more time. Okay, I wanted to show a case. Okay, so we have discussed this. Now there is another case that I wanted to share with you, and I wanted to share the documentation of how we did. It's a live case example that will be able to make you understand the in-depth of nutrition care process documentation. So a 66-year-old male newly diagnosed with hypertension is referred to you. He has visited a dietitian 6 months ago for weight loss. Your previous dietitian who has made a monitoring and evaluation plan. See, a previous dietitian writes a plan so that you can have a unit-based practice, not a individual-based practice. So the plan was, he was first to stabilize Mr. Robertson weight with further plan to initiate gradual weight loss. The indicators and the time frame for success were noted. 2,500 calories per day for weight maintenance, 2,000 calories per day for weight loss, and reduced intake of energy-dense occasional foods to half of the current. From the previous consult, it is also seen from the document that Mr. Robertson was able to answer queries about food to be considered occasionally, risks and consequences of obesity, benefits and targets for physical activity. And according to his self-rating, he said he will be able to meet the goals, and he will take low-energy sodas, soft drinks, half the size of meat service for the evening meal, and increase in non-starchy vegetables and reduction in occasional foods and nuts about 80% of the time. So there was a lot of work that the previous dietitian has done. But in our case, when a patient is coming to us, we only are able to see our implementation, diet education, or maybe a diet chart. In few cases, I have seen a proper structure of documentation happening in Indian cases, right? The lab values of this patient was blood pressure. He is at stage 1 hypertension, 130/90. Lipid profile seems to be normal, and the doctor has provided an antihypertensive medicine, but the patient prefers to start with lifestyle modification. So he's motivated. His anthropometric measure says he's 90 kgs with 29 BMI, and his usual weight was 78 kgs, and he's been able to stabilize his weight from the last consultation that he has done with a dietitian. There are certain details on the dietary intake and the practices and the lifestyle, which is says that he is no longer eating a fruit cake. Previously, he was eating 2 slices. Now he is not. He is taking low energy sodas instead of chocolate coated ice cream. He has done some changes. He has reduced his beer size, but there are certain things on portion size, like example on weekdays, he has not made any changes. When he is visiting his grandchildren's, he has not made any changes. So he is able to recall most of the goals from the progress and the monitoring and evaluation sheet. And there was a detail on energy. Sodium and potassium would be the new criteria, and that we will like to establish. His physical activity was still very sedentary, and he had done no change on it. He has reduced energy, but not to the weight loss level. So on 24-hour recall, he's still consuming 2,700 calories on weekdays, vis-a-vis 2,500 calories for maintenance and 2,000 calories for weight loss, and 3,200 calories on weekends. His portion size of nuts, meat is high. Processed food intake is more. Consumption of starchy vegetable is high. So this is a lot of documentation that has been done, and there is a recall that has been there. And then there is an information on knowledge level, on activity level, which the patient has filled on a scale. Now, when we come on to the documentation part of all the history that I have given as compared to the nutrition care process. Okay, now slides are changing. Yeah. Okay, so when we talk about previous monitoring, how should we document? We should be documenting like the total energy estimate intake. There are certain criteria Mr. Robertson had met. There are certain criteria he has not met. But each category is what you need to meet. When this man takes this paper, he will also be able to self-analyze this. And when it comes to the goal, there are certain things which he has achieved, like he achieved his weight maintenance, but weight loss was not achieved. His occasional foods, there were some digressions into that. The details of the food and nutrition intake, what calories he has taken, what are the behavior determination where he adhered, physical activity, including the intensity, duration, moderation, and where were the knowledge and belief attitudes deficit as per the terminologies which NCP promotes. And all these parameters have been done along with a comparative standard where we say 2,000 calories was prescribed, the desirable BMI range is less than 71 kgs of weight, and the diastolic blood pressure should be 80, and our reference is DASH diet. Right now, coming to the nutritional diagnosis and status. Most of the nutritional diagnosis from previous are active with Mr. Robertson, which is clearly evident on my screen. His energy intake is not there, he is overweight, etc. When I'm writing a PS statement for this patient, it becomes very, very difficult. It's easy when I'm showing it to you. When I give you a story for practicing, it becomes very difficult to write a PES statement. Believe me, excessive energy intake, related to improper food choices, no involvement of social support, and as evidenced by his daily intake versus portion size. Excessive sodium intake related to food and knowledge deficit, as evidenced by his sodium intake on weekdays and his sodium intakes on weekend. Undesirable food choices due to lack of involvement of wife, and every etiology has a parameter. Please see, there is belief, cultural, knowledge, physiological, physical function. Every etiology you need to tick so that you are able to identify an appropriate nutrition intervention plan. Again, the slides are not moving. I don't know. Slides stop moving. not moving.
So just exit the presenter mode, just let it be on the,
Yeah, I'll do that. It's not moving again here also. Are you able to see my slides?
yes, we can see your slides.
Okay, all right. So I'll not do it in the presenter mode. Okay, so moving on from the diagnosis, when we have done a PES statement, this PES statement will help us understand and write a proper nutrition intervention plan. And when we were talking on goals and SMART goals, that is what you need to identify. There are previous goals, there are new goals with a target value, with a time frame, and who is the goal subject and who is setting the goal. Like, for example, social support is one of the goals, because when we studied about him, the wife has been working and wife has not been able to make food choices for him, and hence his occasional food intake was higher, and he was using the occasional food from the market. So setting up goal with the wife becomes very, very important for this patient, and hence the goal setter has to be wife. And his previous consultation, he has said that the wife could not come and see him. So you need to set all the goals and write a proper nutrition prescription like the way we are doing. We all write nutrition prescriptions, but we often falter in writing the goals, which are SMART, which is specific, measurable, achievable, realistic, and time framed, right? So that is very, very important. So this is a clinical study that was done in India for diabetes with ADA. It is called DING studies, and I was one of the part members. The study design was, there were 12, it was a 12-month randomized cluster trial in India. 20 dietitians across India, all states participated, 238 patients with type 2 diabetes. There were two groups, the usual care group and the evidence-based nutrition practice guidelines group. The data collection was baseline, 6 months, 12 months, and the evaluation model was Ottawa model for knowledge transfer. The key findings were both group improved HbA1c significantly. But in the evidence-based group, it was more likely to meet the LDL, HDL, and triglyceride goals at 6 months and 12 months. Significant reduction in triglycerides level was only seen in the evidence-based group, because you were practicing the model and you were writing the correct documentation. But the major limitation was maximum dietitians drop out, because they were not able to write the nutrition care process the way it has been explained and the robust method of nutrition care process. So there were maximum dropouts. There were a lot of implementation barriers, because every hospital did not have an effective EHR at that time.
Charu, can you sum up?
Yeah, I'm summing up, right? So what are the challenges? Last three slides. So challenges in India for nutritional documentation. We have diet diversity. We have resource constraints. We have language barriers. We have healthcare infrastructure issues where EHR is not there. We have training and education issues. Our patient load to dietitian is very, very high, which is time consuming, and it leads to incomplete documentation, and integration with EHR is needed. Awareness and acceptance is very, very important, so that first acceptance has to be there, and we need to standardize video consultation post-COVID. So definitely NCP model is a standardized care model. It is enhanced patient outcomes. It can lead to evidence-based practice, improves the documentation and communication. It gives you professional recognition and development. That is very, very important. It is a quality improvement initiative. It is required that it integrates with the healthcare system, and it will help us use better resource utilization. But what is important is we need to start taking small steps. By the time IDA, I would urge IDA to make a model Indianized way, so that we all standardize and start practicing. And hence I'm requesting Anuja ma'am. But till the time IDA does that initiative and we are able to do it, we should start our journey. We should start education. We should start doing pilot programs. We should collaborate and share with peer groups and see the best practices across the hospital and start making. We have started our journey. Our prescription is made in OPD. We have started. IPD is a different ball game altogether, but we've at least started our OPD prescription. All my dietitians who see the OPD, they follow all the steps and they are writing all the steps in details, though not using the 100% terminology, but critical care thinking has begun, and they are able to time frame their counseling that ways, but they falter when they have a higher patient dietitian ratio. Thank you. Thank you.
Can I, if you allow me, Shweta,
Yes, ma'am, please.
can I make 2-3 comments on this?
Please.
Although a fantastic, again, I will not try to open my video because again, I will go off. Charu is a fantastic, and for the understanding of our BDA colleagues, it's a fantastic presentation, but it is very much, the scenario in Amrita type of hospital, right? We have lot of different kind of, setups in India. We have public sector, we have private sector, we have, nursing homes where, they are not connected. They're all working in their own domains, their own space, right? It is very unlike European countries or UK, where, a person has to first go to GP and he will sort of, refer you to the hospital if required. So it doesn't happen like this in India, first. Second, all these things could be done if the patient dietitian ratio is proper. In public sector, a dietitian may get anywhere between 50 to 70 patients in a day in the OPD. And additionally, she has to see. So this is an ideal situation. But before we implement, IDA through RD board has started taking baby steps, right? To synthesize dietitians what to do and how to do and all that. But you cannot implement till the dietitian numbers increase, right? If the numbers not increase, and that depends I say with all the responsibility, with the attitude and knowledge of the administrators, even to the doctors. There are 10 doctors sitting. Each doctor will refer 10 patients to one dietitian. Tell me, how is it possible? Right? It is not possible in the OPD to make proper nutrition diagnosis. And on top of that, the doctor will write, kindly prescribe to 100 kilocalories diet. I really feel like laughing at that. Without any assessment of their own, they write it. And also, without having a knowledge, a junior dietitian will give 1200 kilocalories without even doing a nutrition analysis. So it is very, you are in a team where you go for all these, for the auditing of all these hospitals and all that, private hospitals, is a very different scenario in different setups, right? First of all, the healthcare, the total healthcare has to understand that dietitian may be actually spending more time in the hospital, right? But it is not acknowledged, right? In spite of that more time, this is very difficult to achieve this bed to bed.
Correct, ma'am.
You see the premier, any premier hospitals, that are public hospitals, where she's seeing at least, I think, how many floors, the dietitian is managing. One dietitian is managing. So how can she put up the note? It's very easy to tell her that, why didn't you put up the note? So I get offended, that they don't even know that how much of load she has. So probably, if you get 10 patients in a day, probably you are able to do it. And maybe it is a scenario in some of the hospitals. But as the patient load increases, one has to also increase the ratio of the dietitians according to the patient. Otherwise, it will never happen.
Yeah, exactly, ma'am. That's what I said in my presentation. Government setups are different, private setups are different, and patient to dietitian ratio to do such a robust model. But creating small, not a detailed one, like where we can just say assessment, we can say diagnosis, not as per all the domains and subclasses. But if we start documenting small things, if not with, I tell my team, if you're seeing 50 patients, my team is seeing, at least do it for 5. Let the journey begin. Do it for the critical care patients, because in India, when the patients come to us, they're already malnourished. They're not, we have done a pilot study with chronic liver disease patients. Yeah, I don't want to do a topic, but then where the diet patients are not visiting a dietitian, that also has been a finding in one of our studies. So that this when we start documenting, and this document we are able to extract, we will be able to show changes, ma'am.
There
What
has to be a different model for public hospitals, for
And
private
for government
hospitals, and the
hospitals.
nursing homes.
Yeah.
We cannot have the same model
Absolutely.
for all.
Correct.
Right?
Yeah.
So RD board, where is Ritu to start working on it? Thank you so much.
Thank you.
Anything you want to say, Shweta?
No, I definitely agree. There is a need to, create a structure for Indian nutritionists. It is not only for nutritionists, it is also for rest of the healthcare professionals. And
Exactly.
I think there has to be more of algorithmic protocols that need to be set so that each one knows, everything needs to be sorted. And also the number of patients per doctor or per nutritionist needs to be sorted because we're all overburdened.
So let me do up my pilot and present it to you after 1 year. We are doing a pilot of this. So let's see how it
Yes.
goes. Wish me luck for that.
Also, I would like to add one point. If the doctor sees 10 patients, the dietitian will be able to see only 5 because she will take more time with the patient.
Yeah.
So this also needs to be understood by all the healthcare professionals that we are counselors, right?
Nazia has written a comment. She has said, same challenges across the world, never enough dietitians.
Yeah.
Everyone has a role in nutritional care.
Yes.
Right. And I think after this wonderful talk, we move on to the next talk. The next talk is what is the UK process or dietetic input into the diabetes care. And the talk would be delivered by Fiona. We have already introduced Fiona. Fiona, please, I think we are already running short of time. I think we can directly go ahead with the talk.
Thank you. Naja, are you okay to share slides again, please? Thank you. Okay, so thank you again. This time around, as Sweta mentioned, we are going to be looking at the dietetic input into diabetes care in the UK. Next slide, please. So just as a quick overview, the things that we're going to be looking at is the prevalence of diabetes in the UK, the management, the diabetes multidisciplinary team, key national guidelines, a real overview of dietetic roles, and then some specifics in regards to the dietetic roles. We are trying to cover quite a lot in this presentation, so there is quite a high overview as we go through, and you'll see. Next slide, please, Naja. Okay, so the prevalence. So what is the picture of diabetes in the UK? So on the slide here, you'll see that the prevalence figures, they're taken from 2023. In the UK, we have about 4 million people diagnosed with a confirmed diagnosis of diabetes. And as we know, diabetes is a complex condition which can take many different forms. So when we break those figures down even further, of that 4.3 million, 8% have type 1 diabetes, 90% have type 2, and then that remaining 2% fall into the category of other types of diabetes. And this might be types of monogenic diabetes. They could be related to cystic fibrosis or rare syndromes, surgery, so on and so forth. And whilst this provides that overarching picture of the number of people in total with diabetes in the UK, we then also have estimations that over 850,000 people in the UK are living with undiagnosed diabetes. So when you put those figures together, we've got around over 5 million people in the UK with some form of diabetes. Now, something that isn't depicted on the slide here is that we also have estimates that more than 2.4 million people are at high risk of developing type 2 diabetes in the UK. So they don't have it yet, but they're at high risk of developing that in the future. And so what you can take from these figures alone is that diabetes is a huge concern in the UK, and this is reflected in our healthcare provision and the services that we provide. Now, just to advise, for the purposes of the presentation, I'm going to be focusing on type 1 and type 2 diabetes predominantly, and this is within adults. So I'm not specifically covering the pediatric diabetes care, which can sometimes look a bit different. Next slide, please, Naja. Okay, so we know that the overarching aim of diabetes management is to keep blood glucose levels within the target range. And on the slide here, you'll see the target ranges that we use within the UK. I thought this would be useful to share, and these may or may not be similar to those that you use in India. I'm not going to read through it, but I'll just give you a chance to have a quick look through. As you know, diabetes, it's a complex condition. It requires a whole multidisciplinary approach to support and manage the condition to meet these targets, but also support those and manage the complications that result as a consequence of poor blood glucose control. Next slide, please. So on the screen here, you'll see an overview of the diabetes multidisciplinary team within the UK. And if we just work our way around this diagram, you can see we've got the general practitioners at the bottom left-hand side there. So doctors are often the first point of contact with individuals living with diabetes, or when they are diagnosed with the condition, they often refer on or to specialists or to diabetes clinics. However, we'll see later in the presentation about how dietitians are also now supporting in this area. We've got diabetes specialist nurse who are doing blood glucose checks, medications, education. And again, we'll start to see where dietitians are supporting in these roles as well. We've got the diabetes specialist, so a diabetologist or an endocrinologist. We've got podiatrists supporting foot health, ophthalmologists, pharmacists, psychologists. And last but certainly not least, we've got the registered dietitians. And this is what we're going to be talking about in a bit more detail. One thing I do want to mention, though, is that the setup and management of diabetes care services varies from one region to another within the UK. It's not the same in all parts of the country, and it will depend on the services available within the locality. And in many regions, there are diabetes clinics where members of the MDT work. Next slide, please. So routinely, when you think of a dietitian, you think about them supporting with diet and nutrition, which is the mainstay of our roles. We provide specialist evidence-based dietary support, advice, education and interventions to support and improve blood glucose control, to help service users achieve a healthy diet and lifestyle, to lower those risks of complications later in life, and to support with weight management, and also support those at risk of developing diabetes. However, the role of dietitians in diabetes management in the UK is evolving. We're being recognised for our unique skill set in supporting the management of diabetes. And this recognition is supporting to reduce the pressure on our National Health Service and also advance our profession. When I highlighted the multidisciplinary team, I mentioned that dietitians are now supporting in other areas which until more recently have been undertaken by other members of the team. This includes diagnosis, self-management education, pharmacology or medications, and technology. Within the next few slides, I'm going to, as I say, give a high-level overview of some, but not all of the areas that we support, so that you can see the breadth of dietetic involvement within diabetes care. Next slide, please. So the first thing to highlight is the key national guidelines which support diabetes care within the UK. You can see that there's a number of guidelines available, and these vary depending on the type of diabetes and the population group. So we predominantly get our national clinical guidance from the National Institute for Health and Care Excellence, or NICE for short. You can see here we've got it ranging on type 2 in adults, type 2 prevention, type 1 in adults. We've got it for children and young people. We've got it for diabetes and pregnancy. We do have some specific ones from Scottish Intercollegiate Guidelines Network, which is SIGN for short, and this is the guideline providers within Scotland, but these are actually done in collaboration or with endorsement with NICE. And at the bottom there, we've got the nutrition guidelines for the prevention and management of diabetes, and these are produced by the Diabetes UK Nutrition Working Group. Next slide, please. So to start with, some key points related to diet and nutrition management within the UK. So nutrition advice, support and management from a registered dietitian is recommended in the UK for all people with diabetes and those at risk of developing diabetes. Within the UK, our approach to diet and nutrition, it has shifted. It no longer takes this line of a prescriptive one-size-fits-all approach. our focus is very much on that person-centered approach. And as I mentioned in my first session, with the service user being at the very center of our model and process, it's not about telling people what they must do. It's all about joint decision-making, supporting and guiding them based on where they are at that particular time, accounting for their culture, preferences, and values. And this approach is highlighted further in our offering of services via group, digital, and face-to-face offerings. Next slide, please. So as we mentioned near the beginning of the session, we have an estimate that more than 2.4 million people are at high risk of developing type 2 diabetes in the UK. And dietitians are well placed to support with diabetes prevention for those at risk of developing the condition later in life. There is strong evidence from randomized control trials that intense multi-component lifestyle interventions incorporating diet and physical activity with sustained weight loss can be effective in reducing the risk of type 2 diabetes in these high-risk individuals. And that's across a range of different ethnic backgrounds. And this is by as much as 50%. So when dietitians are working in this area, their overall aim is to achieve weight loss of over 5%. And they're also looking at improving the quality of the diet, as well as an individual's knowledge. Now, key components of those interventions, as we've touched on, it's reduced energy intake, it's increased physical activity, and it's supporting that dietary modification. Recommendations regarding the specific dietary strategies and patterns, they're found on that key guidelines page so you can refer back to. But diabetes prevention in the UK can be supported by group programs, which are available face-to-face or remotely. So I've put an example on the screen here for you. So we've got the Healthier You NHS Diabetes Prevention Programme. And this is a 9-month evidence-based lifestyle change program, which provides personalised support to manage the weight so they can eat more healthily, be more physically active. And this is now available digitally. So it's improving equitability of access. And it supports individuals through the use of digital tools such as wearable technologies, apps, video calls, and online peer support. Now, this particular program is available in some areas via a group remote setting as well. And this is when this is specifically for people who maybe have specific needs or requirements. So those that might need sign language support, or they have visual or hearing needs. And a dietitian will either support the running of these programs, or they can provide individual advice on a one-to-one basis to support somebody who is at high risk of diabetes. Next slide, please. So another area dietitian support within the UK is diabetes remission. So diabetes remission is considered to be the return of the HbA1c to less than 48 millimoles per litre for at least 3 months in the absence of glucose-lowering medication. And it is achieved, or it's been found to be achieved, from either bariatric surgery or intensive dietary changes to reduced energy intake to achieve weight loss. And that's weight loss over 15 kilograms as soon as possible after diagnosis. I'm not going to talk about bariatric surgery here. I'm just going to be talking about the dietary approach to achieving remission. And regarding dietary strategies, we are focusing on reducing that energy intake. And so when you look at the guidelines, they do recommend approaches, various approaches, I should say, that can support weight loss within type 2 diabetes. And this is where really that we need to be adopting an individualized approach to support adherence. However, we did have groundbreaking research, which you may be aware of, which came from the UK Direct trial. And this saw half of those who went on a low-calorie diet via a total meal replacement achieve remission of their type 2 diabetes after 1 year. A quarter of participants achieved a 15 kilogram or more weight loss, and of those, 86% put their type 2 diabetes into remission. So within the UK, this has led to the establishment of remission programs across the UK. So I've popped one on the slide there as an example. So we've got the NHS type 2 diabetes path to remission, in which they've actually replicated this approach from the Direct trial. So as I mentioned, they're offered, or dietitians as part of a multidisciplinary team offer these low calorie total diet replacement products, their soups and their shakes, and you're really looking at around 800 to 900 calories. And this is for a 12-week period. And across that period of time, participants are receiving support and monitoring. And then after the 12 weeks, they're supported to reintroduce food, but they're then given support for a further 12 months. And as you can see here, there is actually a choice to receive this support in person or digitally. As I mentioned, dietitians are part of the multi-professional team supporting individuals through these programs. And these are programs will vary across the UK. There are well-established, I should say, remission programs in both England and Scotland, but they're being piloted in Northern Ireland and Wales. Dietitians, individuals might come to dietitians as well on a one-to-one basis and want support. They might have heard of this, and a dietitian on a one-to-one basis will be able to support them with other dietary approaches to try and achieve this. The overall aim really is to try and get that 15 kilogram or more weight loss. Next slide, please. So the next element in which we now have seen diabetes dietitians extend to is self-management education. And this is an essential component of good diabetes care. So on average, when we think about it, individuals living with diabetes spend just a couple of hours a year with a healthcare professional, but for the remaining hours of that year, they manage their diabetes themselves. So therefore, self-management education helps those living with diabetes to stay healthy, live well, and avoid life-threatening complications. The overall aim of self-management education is to improve knowledge, skills, and confidence of people with diabetes, enabling them to take control of their own condition. So the area of diabetes care, or this area of diabetes care, was predominantly previously provided by diabetes specialist nurses. However, dietitians are well placed with the correct expertise to support this element of care. Within our national guidelines for both type 1 and type 2, we stipulate that self-management education should be provided to all individuals diagnosed with diabetes. And there are different levels of self-management education available. So we've got group education, structured education, we've got online structured education, ongoing informal learning. This might come in the form of peer support, information and one-to-one advice. And this really does account for that different learning styles and people's individual preferences. Evidence in relation to group structured education has shown that this method improves key outcome, reduces the onset of complications, and specifically in relation to the NHS and our health service, it is also very cost effective when we're doing it in these group scenarios. So dietitians, they do support all levels of self-management education, but particularly within these structured education courses, in which they are often responsible for delivering the service and also then training other educators to provide this across a much wider network. Across the UK, we've got nationally developed education programmes, and in particular areas and regions, we also have local education programmes. So these must comply with criteria that is outlined in our national guidance, and this includes providing tailored education for specific group populations such as ethnic minorities. So on the slide here, I've included 2 of our nationally recognised structured education programmes that dietitians are involved with. So we've got Desmond, which is known for short, so Diabetes Education and Self-Management for Ongoing and Newly Diagnosed, and this is for adults with type 2 diabetes. And this supports understanding, what diabetes is, the risk factors, the complications, appropriate food choices, and about taking control. And as you can see there on the slide, it's also available in a number of different languages, because within the UK, we are a multicultural society, so we do really have to tailor this to the different people that we have in our community. We've also got Daphne, which is dose adjustment for normal eating for adults with type 1 diabetes. And this is a 5-day training course plus follow-up sessions at 8 weeks. And this is really important for individuals with type 1 diabetes, because a lot of the information that they're given here is the mainstay of treatment. Insulin is their main stay of treatment. And then this supports them in regards to injecting the right dose in relation to carbohydrates. So that means they can fit diabetes into their own lifestyle. If I could have the next slide, please. Okay, so another area which dietitians are supporting with is pharmacology or medication management. And this is because in 2016, dietitians were awarded supplementary prescribing rights. So this means that dietitians who have successfully completed the appropriate training can practice as dietetic supplementary prescribers within the scope of their practice. Now, supplementary prescribing is done in a partnership with an independent prescriber to implement an agreed clinical management plan for an individual person, providing this individual person agrees with that. So dietetic supplementary prescribers are predominantly those working in advanced level of practice, and this allows dietitians to support with the prescription and management of diabetes medications. This expansion of prescribing rights reduces delays in receiving medicines, it reduces the number of appointments individuals need to attend, enhances clinical outcomes, and improves patient satisfaction. And within the UK for type 2 diabetes, we've got a range of medications available. I'm not going to read through all of these, but you can see them on the slide there. Generally, the first line of therapy would be the metformin. And then, of course, we've got insulin on there, which is the main treatment for type 1. And, of course, type 2 individuals living with type 2 diabetes who need this as well. And dietitians are well placed and skilled to monitor, interpret data and blood glucose levels and support, assess and advise on the appropriate medication adjustments, particularly in the case of insulin, where we can then also combine our expertise in diet and nutrition and really see why those variations in blood glucose might be occurring. Just as a point to mention, the BDA continues to campaign for dietitians to be upgraded to receive independent prescribing rights, and the work in this area is ongoing. Next slide, please. So for some people living with diabetes, technology can be a really important part of how they manage their condition. And we particularly see this within type 1 diabetes. So diabetes technology in the UK is constantly evolving and improving. And to be honest, I could probably do an entire presentation just on diabetes technology, but unfortunately I can't. So instead, I'm just going to give you that high overview. So within the UK, we've got a range of technology which covers 3 quite broad areas. So we've got technology for taking insulin. So this is like insulin pens or insulin pumps, technology for checking blood glucose levels. So you've got the standard ones where you do the finger prick, but we've also got the continuous blood glucose monitors now. We then have technology to help manage diabetes, such as the hybrid closed loop systems. We've also got digital applications on our phones that can support with weight management or carbohydrate counting. So there's a range of technologies available out there, and this is ever expanding. Now, the diabetes dietitian can support with the provision of diabetes technology, and this really is primarily focused on items such as insulin pumps, those continuous glucose monitors, and those hybrid closed loop systems, as these aren't available to everyone with diabetes on the NHS. So the dietitian must refer to the criteria within national guidance to assess if an individual would qualify. Now, for those that do qualify for certain technology, the dietitian will then provide the training to ensure the service user knows how to use the technology both safely and effectively. And additionally, dietitians are well placed to recommend appropriate technology. This is generally in the form of digital apps that people can access on the mobile phone. And as I mentioned, this will be in the realms of things like carbohydrate counting or weight management. You can find a lot of information all about the range of diabetes technology on the charity Diabetes UK website. And if I could have the next slide, please. Now, the final area that I want to briefly mention relates to quite relatively new roles which have provided new opportunities to dietitians in the UK. And these are first contact dietitian or first contact practitioner roles. And individuals in these roles are diagnostic clinicians working in primary care, and they're working at the top of their clinical scope of practice at a master's level. And these roles allow them to assess and manage undifferentiated and undiagnosed presentations, a role which is ordinarily undertaken by doctors. And within the primary care, this will be, your general practitioners or your GPs. So dietitians in these roles are able to support with the diagnosis of diabetes as well as other conditions related to dietetics by undertaking appropriate assessment and investigations, ruling out those red flags. They do have to have at least 5 years of postgraduate experience, including at least 3 years of postgraduate experience in their professional speciality area of practice. So they would have to have at least 3 years experience in diabetes if they were using that for that purpose. And the title and role should only be undertaken following a period of primary care specific training and assessment. And you can find out a lot of information, if you would like to, under our primary care webpage, including the training and assessment that I've mentioned. And this is it's called the First Contact Practitioners and Advanced Practitioners in Primary Care Dietitian, a Roadmap to Practice. Next slide, please. Okay, so before I finish, I'm just going to very briefly highlight that this session has covered the clinical aspects of diabetes that dietitians support with. However, I think it's important also to mention that when we're thinking of our 4 pillars of practice, we also have to think about the other areas where individuals might be working, and they may work in clinical and still do this. So there's research, there's public health policies and campaigns, and then there's also national guidance development. So there's a lot more that diabetes dietitians can support with. On this final slide, it's some further supporting resources and training just to direct you to. So again, I've mentioned practice-based evidence in nutrition because it does have a lot of information regarding diabetes. We've got BDA courses, and then we've got a diabetes specialist group as well, and they've got a competency framework for dietitians working in the area of diabetes as well. So thank you. That's it from me.
Thank you so much, Fiona, for sharing the dietetic practices in the diabetes. Over here in India, we also use a lot of technology for diabetes management. The next talk, I think, we'll be able to explain a little more. And there are a few questions from the attendees, which there is more about the registration process in UK as a dietitian. So I think we'll take that question at the end of all the sessions. Hiral will take your questions. And to the rest of the attendees, I would request that if there are any questions that are coming to your mind, there is a message box by your side where you're viewing, and you would be able to type that question, and that question would reach us. I think with this, we move on to the second talk. Our second talk is on the diet therapy update, and as per the processes that are followed in India, the diabetes care processes in India. The talk would be given by Dr. Rajiv Singla. Let me share his profile with you. Dr. Rajiv Singla, he's an esteemed endocrinologist working in Delhi NCR, and he is passed out from prestigious All India Institute of Medical Sciences. He has 60 plus index publications and 1300 plus citations. And he received the Best Brief Communication Award in 2014. And the Best Review Award in 2015, and Best Original Articles in 2019, and Best Review Articles in 2023 by the Endocrinological Society of India. His main interest is in type 1 diabetes, transgender endocrine care, and he also has been instrumental in development of ML or machine learning algorithms to help decision support in endocrinology, and that is primarily in the field of diabetes. He has presented these algorithms, machine learning algorithms in European conferences also. I think his talk would be able to gather like what he does. Handing over to you, Dr. Rajiv. It's a pleasure to have you here.
Yeah, thank you. I think, first of all, my sincere thanks to Dr. Shweta, Ms. Anuja Agrawala, and BDA for having me here for this prestigious meeting, which is one of its unique kind of collaboration for understanding between UK and what happens in India. So I think a lot of things that I want to talk about has already been covered by the previous speaker. So in certain parts, I may skip over all those things. I think a couple of things just to make a continuity from previous talk to this talk. I would just like to say that a couple of my observation in what Fiona told us as to what happens in UK is that first of all expense that happens in India happens out of pocket of the common man. So there are no nationalized health services. The insurance is very poorly penetration, has a poor penetration in common population. So naturally, so there is no concept of delivering a diabetes care as an entire single unit to everybody who's got a diabetes. So practically everybody is on their own. So it's generally very difficult to make these processes. There are few standards which has been shared by different societies, but there is no way for us in India to enforce all of them. So we don't have those set of guidelines as nice as somebody has to go through all these processes and this structured program for learning and everything. So I think we are grossly in need for all those standards, and perhaps in some way we should be able to enforce them. Third thing is, I think the team that Fiona showed in the previous presentation, I think that's a dream team. I would love to work in a scenario where I have support of so many people. I think in our clinic, it is me and my poor dietitian who kind of try to fit in shoes from all these processes. However, largely what I'm going to talk about in my talk is with me practicing for more than 10 years now in treatment of diabetes, and then I have a team of nutritionists who work closely with me, and I'm very thankful to all of them for their support in caring for all the people who come to us for their diabetes care. Is kind of to think little beyond what we are normally do in a clinic, and then few things that we generally tend to miss, and a general broad outline that I, as an endocrinologist, believe that we should be doing for people with diabetes as part of diabetes strategy. So this is my conflict of interest statement. And then what I'm going to cover as part of this talk are what should we aim for when we are looking at a nutritional therapy for diabetes. What are the different dietary approaches for managing diabetes? A very gross overview, but kind of just to open everybody's mind as to how do we need to approach it. Then how does a family work as a unit? A couple of slides on that. And then how important personalization of diet therapy in diabetes care is. And then a small word about type 1 diabetes and diet therapy at end of my talk.
Dr. Rajiv, your slides are not moving.
Okay, so is it stuck on the first slide itself?
Yes.
Yes.
Sorry, so I think I will have to go Miss Charu's way by just sharing you with these. Let me minimize it.
Don't make it full.
Yeah, I think it will work as good
Yeah.
as I think as a slideshow.
Yeah.
Sure. Okay. So is it moving now?
Yes.
Okay. Yeah, so I think this is my conflict of interest statement, very important. And then these are the things that I talked about. So I think before I go on to this slide, I just want everybody to understand how important a role of nutritionist in my practice or any diabetes care practice is. Few years back, we were just trying to look through our data for one unrelated study that we were trying to publish and look at as to how people are faring at our own clinic. And during this data, we kind of realized that it is not actually the drugs which are making a difference. So before I briefly show you the results as to what happened with the results, I just want to look at as to what kind of people did we study. So our clinic is situated at a very highly urbanized NCR area, and we cater to lower upper middle class, who people are all very kind of aware about their diabetes, and then they generally are very proactive towards their health. We collected 5 years, we took out 5 years data from our own EMR. We looked at almost 4,600 people with a mean age of 42 years, with more men than women. And we looked at almost 16,000 diabetes prescription, and out of which 8,000 prescriptions were associated with an HbA1c value, to give us an idea as to what makes change in that HbA1c or how glycemic control is achieved. And then at some later date, somewhere around 2018 or so, what we realized was that we need to also record behavioral factor. So we started recording behavioral factors on a Likert scale, which means on a scale of 0 to 5, and then we try to look at how people are kind of faring on those scales, and then whether these behavioral factors are actually associated with glycemic control or not. So what we realized is, first of all, our surprise that higher the number of drugs that somebody was on, higher their HbA1c was. So that was a clear surprise to us. We thought that we are increasing their medicines and their HbA1c would become better, but when we looked at our own data, that was not really true. Now, that does not mean at any point of time, I don't want to say that drugs do not help controlling their HbA1c, but we interpreted it in a way that there is something else that we are missing. So we started looking at those behavioral factors that we recorded in people. And what we realized was that you look at HbA1c and adherence to diet. The more the people are adherent to diet, 5 is like fully adherent, no problem at all. And then 1 is like, I don't care. So if you look at the HbA1c, it comes down from 9.18 to 6.5 in somebody who's fully controlled. So higher your adherence to diet, the more your glycemic control is better. And similar things were true for your exercise. More you adhere to your exercise, at around 150 minutes a day, for 5 days, 150 minutes a week, it becomes stable. So if somebody is not exercising, somebody is exercising less than 150 minutes versus somebody is exercising 150 minutes in a week's time, for at least spread over 5 days, their HbA1c gradually comes down. And beyond that, there is benefit, but not as striking as before that. And then, of course, giving them drugs is only useful if they are adhering to drugs. So the more adherence to drug, the better the glycemic control is. And then testing themselves. If they are testing themselves in any which way versus they are not testing themselves in any which way, makes a difference on their HbA1c, which is clearly contrasting, 8.39 versus 7.47. And then whether they are following up their appointments with their physician or not. First 4 consultations are most important. After 4 consultations, even if they've made it 9-10 consultations, does not seem to make as much of a difference. So how do we interpret this? That people who are adhering to diet, people who are adhering to their physical activity, who take their drugs, who test themselves, who follow up their physician for a reasonable period of time, they are able to control their diabetes even lesser amount of drugs. And vice versa also is true, that even if you are taking more drugs, but you are not adherent to lifestyle factors, so then your diabetes will not be controlled. After this study, I believe that if somebody with new onset diabetes has a choice between an endocrinologist and a nutritionist to choose from, I think they should first choose a nutritionist before they even go to an endocrinologist, because it seems that nutritionists can make a much larger impact on their lives than I as a physician or an endocrinologist can make. Now, to tell you, I think Fiona told us about prevalence in UK. I just want to tell you that this is the prevalence which is there in India. These papers which are recently upcoming, recently means in the last 5 years or so, they are not yet translated into actual numbers that we look from IDF Atlas or from other published sources. What this paper tells us is at 45 years of age in Delhi, at least 23 to 24% of people, of all adult people at 45 years of age would have diabetes, and another almost 45% of people would have pre-diabetes. So in city of Delhi, at 45 years of age, there are 60 to 70% chances that you are either going to be diabetic or you are going to be diabetic, you're pre-diabetic. So that's a huge number. And this data has been replicated in all major cities all across Southeast Asia, which includes Chennai, which includes Karachi, which includes Colombo, which includes Hyderabad, which includes Bangalore. So there are different papers who've been published, and the data is by and large similar. So what we are looking at is that almost 3/4 of urban population has either diabetes or pre-diabetes. So that's kind of pandemic that we are looking at. And then, of course, this is associated with more and more prevalence of obesity in our population also. This is a recent paper published in Lancet, which tells us is that at least 1/3 of country has more than 50% women whose waist-hip ratio is more than what is recommended. In our own clinic, in a paper that we published, we realized that almost even if we go by Indian criteria of being overweight or obese, 89% of people who report to my clinic with new onset diabetes will either be overweight or obese. So we already know that obesity is a major contributor towards pathophysiology of diabetes in people who have diabetes. But what we also know now is that if we lose that weight, I think Fiona already touched about this direct study. I'm not going to go into details of this study, but what I want to say is that if we make these people lose weight to tune of almost 15 kgs or so, there are very, very high chances that these people would be able to reverse their diabetes. Now, there are papers which are published and kind of Fiona told us that in direct study, they were given 800 to 900 kilocalories in form of formula diets for almost a year or so, and then gradually their food was replaced with the normal food, and then they were 46% of people in the study were able to reverse their diabetes, and higher the weight loss, the more chances that your diabetes would get reversed. Then we thought that okay, now acceptance of this kind of a formula diet in Indian context may be low. So what we did at our own clinic, and this is a pilot paper, we've just published a protocol of the diet that we followed in another journal that I'm not showing here, but this is just an unpublished data and we are compiling it for publication, is that in a group of 56 people, when they were given a normal, not a specific diet, not a low calorie diet, not a low carb diet, but in a managed care system in which there was a senior dietitian and then there are junior dietitian who follows up. So it was a three-tiered care system in which we just kind of try to enforce or try to ensure to increase compliance with whatever being prescribed. And almost 37% of people at our own clinic with no special diet are able to achieve reversal. And this reversal dependent upon as to what is the duration of diabetes. If your duration of diabetes is less than 7 years, if you're on less than 2 medications when you're starting off with weight loss process, when your HbA1c, when your fasting blood glucose is relatively controlled. So those are the factors which we can identify in clinical practice, which can tell us, okay, these are the people in whom we should aim for diabetes reversal. Why I'm telling you this is because with this high prevalence of diabetes, we also now know that the new age of onset of diabetes in India is around 30 to 35 years of age. That's where the peak of new onset diabetes now lies. So if we can make these all new onset people go on a reversal journey or a remission journey, as now we more acceptably call it, then that's what we should aim as a part of nutrition therapy, not run of the mill to looking at their HbA1c and try to control that. So in my view, aim of diet therapy for diabetes should be try to achieve remission. Don't look at that weight. We try to optimize that weight and try to make them lose as much as is applicable for their own body weight, and then we should be able to achieve good number of remission percentage in our own clinics. Now, which brings me to the second part of my talk is that generally talking about what do we do about dietary strategies, both for controlling diabetes and also for achieving remission. Generally, broadly speaking, all diets fall into larger categories: low calorie diets and low carb diets. Now, everybody know about calorie restriction, but generally we tend not to talk about carb restriction. I think two things that we need to understand when we talk about low carb diet is that insulin is a weight multiplier. Insulin is responsible for storing extra energy in form of fat in our body. If there is no insulin, then nobody can store fat. So if your carbs are low, if your insulin levels are low, so then generally your body is not able to store those fats. And vice versa, if you cut down on carbs, if you've already got stored fats, then it would be easy for body to undergo that fat catalysis process, the lipolysis as we call it. Second thing is insulin is the one thing which drives your hunger. Apart from first 7 to 10 days or so, if people are on low carb diet, this is the only diet where people actually don't feel hungry and their cravings go down as their carb content in the diet goes down. So that's a very, very useful thing in a clinical practice to hold. Generally speaking, I believe that, okay, so now we have different kind of diets. I think all of you know it better than me. Only thing is that I want to point out that the diet that we normally Indian takes are very, very high on carbs. It is almost 70 to 80% carbs that we take in our own diet. As far as these different diets are concerned, I think we generally tend to, I generally tend to believe them. There is a spectrum. At initial beginning end of spectrums are these diets are easy to follow, more sustainable, but they are less efficacious. As we go down the spectrum, these diets become more efficacious, but then they also become less sustainable over long-term diet. First is a standard calorie deficit diet. We kind of try to look at what somebody is taking and then keeping routine and everything same. We tend to reduce their calories according to their BMI and everything. I think that's what everybody starts with and does with. But as we move on across the spectrum, we add some calorie restriction, but early on we start adding some amount of carb restriction, which is not actually going towards ketogenic spectrum, but like say limiting it around 150 grams a day or something like that, which is like at baseline in most Indian diets that we've seen is around 250 to 300 grams a day. We try to bring it down gradually to around 150 grams or so. And then once we've done that, if we still need more zinc in our diet or it is still being less efficacious, then on same diet, try to add some other things like intermittent fasting or things like that. Of course, somebody with diabetes, somebody with insulin, somebody with drugs which can have a potential to cause hypoglycemia, you need to be very, very careful. And then me and nutritionist has to work as a team, change their drugs to make this happen. Then if still not working, then we go on low carbs diet to the tune of keto diets, and then eventually the formula diets as was done in the direct study and as a remission program in the UK tries to follow them. So two large broad categories, try to mix them in a different way. Practically how to do that, how to reduce calories and how to reduce carbs, I think every nutritionist what their salt knows better than what I can tell any of you. I think I can't emphasize, I just saw yesterday a patient 16 years old has an HbA1c of 6.2 with a weight of 127 kgs. Both parents around 130 135 kgs. And both of them has diabetes, both of them are kind of on insulin and nobody knows what to do about it. I think this is one clear lacuna that we need to understand. One, that of course this is a genetic in nature, I can't deny that, but the environment in a family also matters. If somebody comes to you with diabetes and tells you that they've been taking soft drinks in their diet, I think all family members are taking those soft drinks. So I think it is a good idea to ask them what is there in their refrigerators, and then we need to tell them, we try to treat family as a unit, which is not good for somebody with diabetes under your care is not actually good for all those people. And looking at prevalence of diabetes that we have in our city, in our urban areas, I think we all need to understand that removing environmental factors, improving environmental factors in a family unit leads to much better longer term outcomes than just focusing on one person in that family. Second thing, I think because of evolution, everybody knows that our body is geared more towards gain of weight than loss of weight. So gaining weight is easy, but losing weight is where the body resists. And all our traditions are built based upon the evolution, where till 50 years back, having more weight was considered to be good because it was good for your life, and then people used to live longer if they had higher weight. Till that time, there was no abundance of food. That evolution was good till food scarcity was the general rule. People were dying more of malnutrition than of diabetes and weight gain. So I think we also need to kind of tell people that this is the time when evolution has changed. Our basic premise in evolution has changed. We need to dissociate our quality of life from food. Celebrating all your family occasions with food is no longer a great idea. So treat family as a unit, dissociate food and perceived quality of life in our life. I think we gradually work on it with our people. I think but that's the way to go about it. And then looking at people, affecting people who are not directly under your care is going to be by using these things. And I think Fiona had already touched on this personalization of diet plan. Let me tell you, in practice, and we learned it in a hard way, choosing practical over what is best is always a great idea. Something which is best and we think that people can do it, while they in their practice, in their clinical situation, in their family situations, when they can't do it, is a recipe of failure. We need to look at each and every person, what their work schedule is, what their food habits are, and then who is going to make food at the home? Is it possible for that person to cope up with so many other things that we are asking them to do? Is that possible? So we need to look at all these factors and then come up with a plan which that person can follow. And I can give you I can give you a few examples. For example, if say suppose I have diabetes and I am a doctor, physician, I work from 10 o'clock in the morning till 6 o'clock in the evening. If somebody comes back and asks me, okay, you have to have these 6 meals in a day, I don't think so that's possible for me to have. While it may be best for me to have those 6 meals, but if I really can't have it, I really can't have it. Then giving me that prescription is of no use. Moreover, 6-meal diet plan was applicable when there were not many drugs to treat diabetes. And we had a very, very limited armamentarium, and we just wanted no postprandial meals to go higher. And now we are talking about intermittent fasting. So you see it's a diametrical opposite end. We're asking people not to eat for prolonged periods of time. And that's actually in contrast with 6-meal pattern. So 6-meal pattern, for somebody that works, it works very well. But if it is not practical, let's not get hooked on to saying that, okay, this is what something should do. Night shift work hours, munching during night working, I think we need to get away with. Somebody who gets up at 3 o'clock, their breakfast is going to be at 4 o'clock in the evening. Their lunch is going to be at 9 o'clock or so. And then their dinner is going to be at maybe 2 o'clock or 3 o'clock or so. And then they would go to bed at 5 o'clock or so. So that's how we need to schedule their diet. And we should absolutely tell them that the nighttime munching is just not accepted. Diet during traveling. If somebody is staying in hotels and say, I can't eat homemade food, how do I go about it? Take your food in 3 helpings. Choose only fibers, only salad in first helping. Take that helping on your plate, sit down, eat all that up. Don't take anything else. Take second helping of proteins in whatever way. Sit down, eat that, don't come back. And then third helping is whatever you want to eat. Your carbs, your roti, your chapatis, your chawals, and then along with other vegetables. If you follow this, generally, at least in my practice, when I tell them generally to do this in a buffet setting, in whatever hotels they are staying, it has worked very well for people. So that takes away this thing. And I think diet in postpartum period for somebody who's got GDM and type 2 diabetes, as in our South Asian practice, I think all across Southeast Asia, we believe that to give carb and fat-rich diet to women after their diabetes and GDM. I think that also is rooted in evolution in our traditions when we were not giving women to eat anything while they were not pregnant, while during their pregnancy. Now everybody cared for their child. Everybody wanted milk production to happen. So they were like, go gaga over women and then feed them more so that the child is safe. I think now we are in an era of food sufficiency. Everybody's got enough food to eat. People, if somebody's already got a GDM and type 2 diabetes, they are not energy deficient at any point of time. So actually giving them more carbs and more fat during postpartum is doing them more harm. So telling them that these traditions are not applicable to us now would give us a great benefit and opportunity that we should not miss. We may prevent these people from having diabetes in long term. A little word about lean people with diabetes. I think what we need to believe is that lean people with diabetes, if they already have diabetes, which means that their metabolic rate is not that great. So generally, lean people who've got diabetes has much lower personal fat threshold, means that they can't store fat in their abdomen. So that's why this fat goes to their liver and then eventually goes to insulin sensitive issues to cause insulin resistance. So people who are lean, who do not have much fat to lose, actually benefit from are actually has more insulin deficiency. And now, in an era of subtyping of type 2 diabetes, we would see that more and more personalized diet advices are going to come. Like, for example, somebody who's got a mild obesity-related diabetes or mild age-related diabetes, putting them on a calorie-restricted diet, or for that matter, low-carb diet, is going to work very well. They can achieve remission very well. While people who've got insulin deficiency, who are little lean, their resistance is not that high. Perhaps choosing little lower carb diet in them is going to be very, very useful. However, in them, we should have a balance between how much weight can they lose and how much glycemic control do we achieve, and can kind of taking help from drugs in their case may actually be little useful. Why I'm trying to tell you is this, because a lot of run-of-the-mill diabetes reversal programs that are running in our country, they just focus on a very low carb diet, making people lose weight, which if somebody already is lean can really be counterproductive in the longer run. Because our purpose is not in short term to reverse diabetes, but to increase quality of life and increase longevity of life, which beyond a certain limit of weight loss may actually be harmful in the long run. Now, of course, managed diabetes care is the thing, or which is kind of needed. I think Fiona showed this thing to us in a much more comprehensive manner than I can. Just the last part of my talk, I think what we need to understand is type 1 and type 2 diabetes are two different diseases. Type 2 diabetes comes with a baggage of metabolic syndrome. We need to look at weight issues. We need to look at people generally are older in their age, and then they've got deranged lipids, they've got CV risk and all those things. Most of these things are not required in type 1 diabetes to be restrictive. In general, diet in type 1 diabetes is supposed to be much less restrictive as long as we can count those carbs. I can't emphasize more that there is no restriction on fat in children with type 1 diabetes, at least till 30 years of age or so. After that, we also need to look at their CV risk reduction and everything. So anybody who's less than 30 years of age, has no complications and is doing fairly well, I don't think so we should be restricting their fat. They should be taking fat as per their age, appropriate fat should be doing, and not kind of, there is no fruit which they cannot eat. There is rice which is not that it is prohibited for them, because we keep on seeing these children with type 1 diabetes who are really, really made to follow diet advice, which may be appropriate for type 2 diabetes, but not for type 1 diabetes. So please understand, they are two different diseases. The restrictions in type 1 diabetes are generally very, very less. So just to summarize my talk, we should be aiming little higher. We should be aiming for diabetes reversal, not just run-of-the-mill control of diabetes. The restriction of either calories or carbs are two different ways, and all other kind of diets fill in one of these two broad categories. We need to treat family as a unit, and we need to dissociate food from perceived quality of life as much as we can. And personalization is the only way to ensure that nutritional plan or diabetes control can be sustained in the long run, and diet in type 1 diabetes is much less restrictive in general as compared to type 2 diabetes. With that, I would say thank you. Any questions are most welcome.
Thank you so much, Dr. Raji, for the wonderful talk. I think he has made a point over here that not all diabetic patients are same. There are different types of diabetes. Diabetes in a lean patient, diabetes in a pregnant woman, diabetes clinical scenarios differ in different type of patients. I would request Najia and Miss Anuja ma'am to comment and join the discussion for a few minutes if there are anything that they would like to add to the perspective.
Should I go first?
Please.
Yeah, so it was a fantastic presentation, Dr. Rajiv. I think it's so practical. I think a lot of our dietitians would like this kind of tips, and it has to be, the presentation should be like this. And you made a point there. I just wanted to ask you, I don't see much of type 2 diabetes, but I really want to ask you that every home has type 2 diabetes. Do you actually see reversal of diabetes, and they actually come out of their medications also and continue to do a dietary proper dietary protocols and live the whole life?
Yeah, of course. I think that's the point. I showed you my pilot, Sanuja. I think, and that's what we do now. Almost 37.5% of people in that study that we did at our clinic were off all medicines,
All right.
and then it's our standard aim of therapy now in everybody who comes to us with a new onset diabetes. That's what we do with them, whether they choose to be with us with a managed care, even if they don't want us to be with a managed care. The first message that we convey to somebody who comes to us is that this can be, diabetes can be made to go into remission. And that's what we should aim for.
Right. Thank you so much, Najia.
Yeah, absolutely. Actually agree on all points that you've made, actually, Dr. Rajiv. It's a tricky one, isn't it? I think it all stems around the motivation of the patient. At the end of the day, they're the ones that put the food in their mouth or choose not to. And that's all about behavior change. And that's one of the things that we're recognizing solely how dietitians, how much, well, not just dietitians, actually all healthcare professionals have in this role on behavior change, because a lot of it comes from that. And if they're not motivated to change, it doesn't matter how good the system is in the UK, India, how many drugs we have, how many, education, forums we have. If the patient isn't wanting to change, isn't in that position to want to change, doesn't have that system, as you've said, around them, the support system, whether it's family or they have so much of a social life that actually, trying to choose in restaurants and various other things, or just don't have the money to choose what goes into their mouth. It's so difficult, isn't it? So we've got a huge challenge. We talk about pandemic of COVID, we've got a huge challenge if we just pick diabetes. So no answers here. We just have to deal with what's in front of us. It's a challenge. Sorry, no answers.
Charu, I think you want to ask something.
Yeah. So first of all, I would congratulate Dr. Rajiv. It was quite an insightful thing and a lot of good work that you are doing. That is what was very evident. I just wanted to ask, out of curiosity, Dr. Rajiv, like when we prescribe diets, very low carb diet to the patients, like, and when you talk about remission diets, like 800, 900 calories, where you don't have meal replacers and all, how is the compliance? For what period? Like, because these are all short-lived. What we see is a yo-yo effect happening quite often. So what has your experience been, sir?
So I think I would say that, see, first of all, I think even in the direct trial that Fiona shared, they were not made to be on that low-calorie diet forever.
Yeah.
They were started and then they were gradually shifted over to the normal diet. What was more important was, and I think is, and I'm not saying it from that trial's investigators' point, is that you lose weight and then you maintain that loss. If you are able to do that in whatever which way, it generally works. As far as low carbs diet, of course, if you go to a ketogenic spectrum, then for us Indians who are largely vegetarians, it's a huge challenge. For somebody with non-vegetarian habits, it may still be doable in the long run. I was part of a ketogenic startup, and I put myself on a vegetarian keto diet, and that was like 4 years back. And I'm still not able to eat that paneer tikka when it comes in front of me because I ate so
Same.
much of it those 3 months that I still get little nausea when I see that. Third thing is, I think and that was the reason when we did at our own clinic. So we didn't go by low carb or absolutely low calorie diet, but I believe even with normal approach, and of course, I didn't have time, but I could have showed you that other time. But most of our people went into remission when they were around 1500 kilocalories every day, but they were on almost 140, 150 grams carbs every day. So that was the combination which came out best, in which compliance was also good and the efficacy was also good for large majority of people.
So if you reduce the carbohydrates, of course, you increase the proteins there, right? And the fat also, right?
Yeah, so see, if it's a so what we did was our protein intake was by and large stable in the when we went back and analyzed it, and then our fat intake went little up. This thing, but in absolute terms, as a percentage, yes, fat went up. But if you look at in absolute terms, when people started, they were almost taking 2500 to 3000 calories. And when we brought them down to 1500 kilocalories, if you look gram by gram, actually everything went down.
Absolutely.
Right.
So, yeah, I agree. We have also experienced such kind of results in our practice when it is on a 1400 or 1500 calories diet. So till the time they are following up with a dietitian, what I've seen is their compliance is really good. So the DINK study, which I was talking, was also talking about this. But as soon as the compliance goes away, I have seen double things. Some people will continue, but some people will not be able to continue. So sustaining a low carbohydrate diet in India becomes a little more challenging. Like sustaining a low protein diet for a renal patient abroad is challenging. Low carbohydrate diets in India is equally challenging with diabetics because we are all across, it's all carbohydrates. We also counsel our patients, snacks khana hai to protein wala hi khana hai. You don't have to eat a carbohydrate snacks, and we give them the options of protein based snacks. So people who understand it, yes, have benefit. I echo that with you, Dr. Rajiv.
Even with protein, there is a problem. Our kidneys in diabetes, they can't take so much of protein.
Yes.
It is people are very hyper increasing the proteins, but I feel they should be really cautious.
Absolutely.
In India, increasing the protein.
Yeah, especially with the new NIN guidelines, ma'am, that have recently come up, and the revised RDA, where only 0.8 gram is recommended for a normal population. So yes, we definitely have to look in. But because they're not eating 0.8 gram, that's where we try to.
In children, we start seeing albuminuria very early if we increase a lot of proteins. So, I mean, one should be very cautious.
Yes, yes.
I think it
I
was
think the other thing is we don't know the implications of all the new wonder drugs that are out there at the moment and promising weight loss, and we've just had it agreed on the NHS to be able to provide for our patients, but we don't know the long-term effects. No magic solutions here, but who knows where it's going to go.
I think I would just like to comment on this, Nazi. I think you raised a very, very valid point. I've been telling people this, that losing weight by lifestyle and losing weight by drugs is not equivalent. There is not a single paper which tells you that losing weight by drugs would give you equal cardiovascular benefits as losing by lifestyle would do. All these people are just extrapolating from lifestyle data and trying to tell you that weight loss is a weight loss. I just had one patient today who lost 16 kgs on dapagliflozin.
Yeah.
We have not been able to reduce any of his medicines. he has lost weight, he's lost muscle mass, he's feeling miserable. While we just talked that there are 85% chances that if you lose 15 kgs, your diabetes should go into remission. So in my mind, there is no doubt about it that losing weight with drugs is not a great idea.
It's
And
not the
I'm
way
not
to go.
sure what we are going to look at those things in the long run.
You're just storing up trouble.
Absolutely.
Anyway,
I think it was a very insightful discussion after the talk. And as we are running short of time, we move on to the next talk. Our next talk now moving from diabetes to epilepsy. And in the next talk, we are going to talk about diet therapies which are successful in epilepsy and what are the challenges associated with it. And the talk is by Dr. Subhasini Sharma. Dr. Subhasini is already here. Let me just share her profile. She has been a brilliant scholar. She is a pediatric neurologist and a fellow in pediatric epilepsy from Toronto. And she is currently working as a professor in departments of pediatrics and running pediatric neurology clinic in Lady Hardinge Medical College, New Delhi. With a massive publication database with her too. She has 240 publications. She has written 30 book chapters, avid academicians. Her special interest includes dietary therapies for epilepsy, SUDEP, infantile spasms. And she has won multiple awards. Dr. Janki Memorial Oration Award in 2022, Sheila Wallace Award in 2020, Bernard D'Souza Award in 2018, and Dr. H.B. Dingley ICMR Research Award and IAP Young Research Award in 2015. And I welcome Dr. Subhasini. Welcome you, Dr. Subhasini. Handing it over to you.
Thank you, Dr. Shweta, for that lovely introduction. Can you see my slides?
Yes, we can.
Okay. So we will talk about ketogenic diets in another setting now, from diabetes to epilepsy. And in fact, they came much earlier in epilepsy than for weight loss and diabetes. This is metabolic indications are more recent. This has been going on for more than 100 years now, the epilepsy indications. So ketogenic diet is a high-fat, low-carbohydrate restricted protein diet, which leads to ketosis. It has to be done under medical supervision. And so, like I said, it's been around, at least documented uses like more than 100 years now. But even before that, even in the Hippocrates times, it was known that fasting reduces seizures. Even in the Bible, it has been mentioned that mentioning of fasting reducing seizures. And there's some writings that Lord Buddha also had epilepsy and he cured the seizures by fasting. But in the modern medical world, it was in the 20th century. So there was an osteopathic physician, Hugh Conklin, who used fasting to treat 16 children with epilepsy. And he found good results of seizure control. But of course, fasting was very difficult for children to tolerate. It was Dr. Wilder in Mayo Clinic at that time who figured out metabolically that a diet which is high in fat and low in carbohydrate would mimic the metabolic effects of starvation. And Wilder was the person who coined the term ketogenic diet. And remember, at this time, 1920s, there was really no anti-seizure medication available other than bromides. So throughout 1920s to 1940s, ketogenic diet was actually the only treatment available for epilepsy, and it was effective. In 1939, something big happened. Phenytoin was discovered. But even Dr. Houston Merritt, who discovered phenytoin, said that I have done the greatest disservice to epileptics, the discovery of phenytoin, because with this, research into metabolism of epilepsy and the mode of action to the ketogenic diet will stop. And after that, of course, many other anti-seizure medications came, including the wonder drug sodium valproate, which is a broad-spectrum anti-seizure medication in 1974. So really, ketogenic diet kind of went into oblivion. But a few centers like Johns Hopkins and Mayo Clinic, they still continued it for some of their patients. So in 1994, there was a film producer, Jim Abraham, whose son was having drug-resistant epilepsy. and medications and 3 surgeries did not help. And he was researching and he found out about Johns Hopkins and the ketogenic diet. And his seizures got, he became seizure free on the ketogenic diet. And Jim Abraham made a movie about this starring Meryl Streep. So ultimately it became famous, it came into the media. And since then, there's been a huge resurgence in the diet. And the last 25, 30 years, and it is now the accepted treatment option for refractory non-surgical epilepsy. So any person, any child or adult who has seizures which are persisting despite 2 appropriate anti-seizure medications is said to have drug-resistant epilepsy. And these patients, what we need to do is first to see if they are surgical candidates by means of MRI and EEG and other tests. But if they are not surgical candidates, then the ketogenic diet is a very good option in these patients to try. And now there are less restrictive variants. We have enough experience now for the last almost 15, 20 years for modified Atkins diet, low glycemic index treatment. And the diet is now just not only for epilepsy, but many other neurological conditions like brain tumors, Alzheimer's, autism, ALS, Parkinson's, and even non-neurological conditions like PCOS, acne, and diabetes, obesity, metabolic syndrome. So I will just give you some basic tips about how this diet is actually administered. So one thing to understand is that it is a medical treatment. Just like we tell patients that they cannot just, a person with epilepsy should not just start anti-seizure medication on their own. Similarly, this diet also is a treatment. It is a treatment with its own, the way it is to be given with its own side effects. So what is needed is a very trained dietitian for this and a physician who could be a pediatrician or a neurologist who is familiar with this diet. So this diet requires strict calculations. The diet is calculated. This is 4:1 is the classical diet, this is a ketogenic ratio of fat to carbohydrate to protein. These high ratios are now used in very rare circumstances. We can get away with much lower ratios like 2:1 or 2.5:1. So how is this diet started? So the original protocol, which was followed at Mayo and Johns Hopkins, was a fasting protocol where the patient was fasted for 48 hours. And on the third day, 1/3 of the calories were started and gradually built up to full calories by 5th day. But of course, fasting is very difficult for children and adults to tolerate. The advantage of fasting is that it leads to rapid ketosis and quicker seizure control. It's like a loading dose of an anti-seizure medication. And one more advantage is that if there is some underlying inherited metabolic disorder, because there are some contraindications to diet. So during fasting, if there's something, if the patient worsens, then we know that maybe there is an underlying metabolic disorder which has been missed on the screens. So of course, but the disadvantages are many more. It's very difficult for patients to tolerate. It has its complications like hypoglycemia, and of course, it needs inpatient admission. So by and large, most centers across the world have moved to a non-fasting protocol, which has less complications. It is outpatient. It is better tolerated. So there are many ways of doing an outpatient initiation also, the non-fasting initiation. This is one of the methods which is described by Bergquist et al. So what they did was instead of fasting for 2 days, they will start with a lower ratio, 1:1 the first day, 2:1 the second day, 3:1, and gradually build up to 4:1. And another method has been done by Dr. Nathan's group, which is a carbohydrate washout diet. So for the first week or so, they really make carbohydrates as almost zero as far as possible until gradually the ketosis start coming, and then move to a more relaxed, not really relaxed, but a more like carbohydrates are introduced in a phased manner. So earlier studies would also talk about calorie and fluid restriction because this had been shown to improve seizures in animal models. But there is no evidence in humans, and really in our kind of climate, we should not even think of fluid restriction, and even calorie restriction is not recommended for purposes of growth and energy levels. So this diet is, of course, as all of you would know, is very restrictive. We cannot have any fruits, very few of the vegetables. So though it will definitely need supplements like multivitamins, minerals, calcium, vitamin D. Optional supplements are oral citrates for preventing renal stones, laxatives, because constipation is a common side effect, and selenium, magnesium. So basically, they need to give multivitamins. Most of the standard multivitamin preparations will have selenium, magnesium, zinc, the amount that is needed. And optionally, carnitine, MCT oils can be considered because MCT also is a ketogenic oil. And of course, all the concomitant medications should be given as carbohydrate-free preparations. This again becomes difficult for young children when all the syrups need to be converted into tablets. But this is important, otherwise the ketosis may break and the child can develop seizures. So regarding efficacy, earlier studies were all case series, retrospective, prospective, and overall, by and large, what most studies showed was that if you have 100 children with drug-resistant epilepsy and the ketogenic diet is tried in them, 50% of them will have a better than 50% reduction in seizures. Around 10 to 15% or maybe 20% become seizure-free, and but 50% will not respond. So, and this has been proved in randomized controlled trials with the control group just continuing anti-seizure medications. And so even the Cochrane review has collaborated, at least in the short term. It definitely, because most studies would have studied up to 3 months, 6 months, and maximum 2 years. We do not have long-term data because long-term, definitely there is a high dropout rate because it is a difficult treatment. Who are the patients who are likely to benefit? So there are some conditions wherein it is really the treatment of choice, and there is no two doubts about it. And one of them is glucose transporter 1 deficiency, GLUT1 deficiency. This is a condition wherein in the brain there is a deficiency of the glucose transporters. So the brain cannot utilize glucose as fuel, and so an alternative fuel has to be given, and this can be given by the ketogenic diet because then the brain utilizes ketone bodies as fuel. And another metabolic condition, which for this ketogenic diet is treatment of choice, is pyruvate dehydrogenase deficiency. These are the metabolic conditions. Other than that, infantile spasms, myoclonic astatic epilepsy, tuberous sclerosis, Dravet syndrome, these are conditions which respond very well to the ketogenic diet. And after, say, 1 or 2 standard medications have failed, one should not, as far as possible, fool around with too many anti-seizure medications and start the patient on the diet as early as possible. So what is also important is that not everybody is a candidate. There are contraindications as well. And what is most important is that patients who cannot metabolize fats. So patients with beta oxidation defects like medium chain acyl dehydrogenase deficiency, MCAD, LCAD, all these fatty oxidation defects, carnitine deficiency. But by and large, these patients will not present with epilepsy. They have other features and it can be clinically detected. But if we have a child with unknown epilepsy, unknown etiology epilepsy, and there is a suspicion of an inherited metabolic disorder, it's always better to exclude it by a genetic testing or a metabolic screen. Relative contraindications are if there is a surgical focus, then of course the patient is better a surgical candidate. But for surgical, but even in these patients, because sometimes epilepsy surgery can take a very long time to happen, in the interim, patient can be given ketogenic diet to help with the seizure control. Complications. So it is, like I said, it's a treatment with its own side effects. So the most common complications are gastrointestinal, constipation being the commonest one. Vomiting is common in the initial phase till the child becomes adjusted to the high-fat diet. Renal stones were earlier reported in 3 to 5% of patients, but once the monitoring protocol was advised that we monitor the spot urinary calcium creatinine ratio, and if it is exceeding 0.2, start the patient on potassium citrate. Overall, the incidence of renal stones has reduced. Growth problems are expected and do happen for children who are long-term on the ketogenic diet, macronutrient deficiencies. Dyslipidemias can happen, but if the patients are given a good combination of saturated PUFAs and MUFAs, then the incidence of dyslipidemias is not that high. And very rare complications are pancreatitis infections. I would not say rare. In the Indian scenario, infections are a little common, I would say, at least in our low socioeconomic patient scenario. But then the other thing is that these children are already frail. Kids who have drug-resistant epilepsy, they have comorbidities like global developmental delay, cerebral palsy, malnutrition. So these kids are anyway prone to infections, and with this diet, the aspiration pneumonia conditions can increase. So how is the diet to be discontinued? It is an individualized decision. So one size will not fit all, but first of all, we need to give it for at least 3 months. Some people would even say 6 months to declare it successful or unsuccessful. Because unlike a drug where you might decide after 2 weeks or 3 weeks that it's not working, for diet, that metabolic alterations in the body and brain take time. So it's very important to counsel families about their realistic expectations in the beginning itself, that this is going to be a lot of hard work, but please do it at least for 3 to 6 months before, make a commitment that you will try at least 3 to 6 months before you decide to give it up. And if it is working, it is given for 2 to 3 years. And of course, in condition like root 1, it has to be given lifelong. And it is discontinued by reducing the ratios. And now I'll talk about a little bit about Indian experience and how basically this is my personal experience with the diet. So this was somewhere in 2006 when I was doing my DM, and I'm so happy that Anuja madam is also here, and she will be able to also give her own experiences that we experienced. So when we started working on the diet, so at that time it was considered a very fatty diet. There was really no experience, at least in North India. We knew that in Mumbai, Dr. Nathan was doing it, but that time we hadn't. Things were not so easy. Like now we have webinars and things, and people so much access to resources. So it was not the case almost 20 years back. And we knew that fasting is just not going to work with our patients. There was also limited availability of labeled foods and so when I was reading these books, this was the initial John Freeman books, and they talked about things like 36% high fat cream, which was not even available in India. We didn't have sugar-free products. Formula was not available. Even now, I mean, even if it is available, it is priced so high that it is beyond the price range of most patients. And high prevalence of vegetarianism, already talked about in the last diet. A lot of cynicism from the medical fraternity, I would say, especially the adult neurologists and trained dietitians, paucity, definitely, because it was such a new thing. And this was the first study this was my DM thesis. And despite all these challenges, we went ahead and Indianized the recipes, and we did the diet in children having daily seizures despite 3 anti-seizure medications. We used 4:1 ratios in children more than 18 months and 3:1 in younger children. Children were hospitalized for initiation because we were doing it for the first time. But we did use the non-fasting gradual initiation protocol. And we were very happy to see that the results were just as described in the Western literature. We had 50% patients who had better than 50% reduction, and 11% had become seizure-free. But of course, there were a lot of adverse effects: constipation, weight loss, vomiting, 2 patients had hypoalbuminemia, 3 patients were severely ill, required ICU stay. So it was not a treatment to be taken lightly. And of course, the problems we faced, number one, so our dietitian had to multitask so much because she had to look after all the dietary needs of the children in the hospital, inpatient as well as outpatient. It was not just ketogenic epilepsy thing that she had to see, but also diabetics and celiac and renal and obesity, so many, and metabolic, a lot of inherited metabolic disorders. So it's not possible for one person to do everything. And this actually requires probably more work than the other conditions, like I would say diabetes or renal, where you can have general guidelines for the patients. But the ketogenic diet is tedious, individualized calculations, which will take several hours. And of course, we were hospitalizing patients at that time, so bed availability was an issue. The non-availability of labeled foods. And of course, it was not a very easy treatment for patients. They had to buy a digital weighing scale, keto sticks. Understanding complicated instructions was difficult for parents with low levels of literacy, predominant vegetarian population, very, busy mothers, so especially working mothers, that spending time to separately make food just for the child. Cultural issues in joint families. Parents may want to give the diet, grandparents feel the child is being starved. Storage issues, if people don't have a fridge, and with our kind of summers, hot climate, how do you store things like cream and heavy cream and things like that needed for the diet? And of course, all this led to a very high dropout rate. And by this time, so papers started coming up that maybe you don't need that higher ratio. And there was a paper from South Korea wherein they compared a lower ratio 3:1 diet with a 4:1 diet and found both of them to work. And Dr. Nathan's group also published their data. They were using really much lower ratios, like 2:1, 2.5:1. So we went ahead, and this was Dr. Vaikuntha Raju's TN thesis, wherein we compared a 2.5:1 ratio. When you lower the ratios, obviously you can understand that we can get more carbs in, and this makes the diet more palatable, more closer to the regular diet that the child eats compared to 4:1. And again, both diets were equally effective, and there was really no change in biochemical parameters. And in 2000, around this time only, these papers started coming up about the Atkins diet. So Atkins diet, of course, was for weight loss. And it was, so how the way they started was in Johns Hopkins. Like I said, they were doing ketogenic diet for decades, and they always had huge waiting lists. And some of the families themselves figured out that Atkins diet also leads to ketosis. So they started using the diet by themselves, still while awaiting the formal admission for the ketogenic diet. And there was a series of patients who responded, and they did not even need the ketogenic diet. So it was Dr. Eric Kossoff and their group. They started publishing papers on the use of Atkins diet. They call it modified Atkins. Their modification was that carbohydrates were restricted to. So one modification was it's not for weight loss; it's for epilepsy. Carbohydrates are restricted to 10 grams per day and 20 grams in adolescents. And so this is the initiation phase. It kind of continues. They don't go into an increasing phase, at least at that time, that was the thought. And instead of just allowing fats are actively encouraged. So of course, it was a simpler alternative, no hospitalization required, no protein restriction, easier for doctor. And for them, the parents just read the book. And so in their, in the US, they had already lots of Atkins food available in the grocery. So it was pretty easy for the parents to do. Of course, when we started it, this was not we could not just give this book to the parents and say, you read it and figure it out yourself, like was being done in the US. So what we did was we kind of modified it to our settings, wherein we followed the basic tenets of the diet that carbohydrates were restricted to 10 grams per day. But what we did was we made it simpler for the parents. These carbohydrate was divided into 4 2.5 grams, along with a list of free foods or foods which do not contain any carbohydrates. The child can eat these foods as much as they want. And other than that, they eat 4 of these 2.5 gram each carbohydrate each meals. So fats are actively encouraged, proteins unrestricted. So this was the guidelines we gave them, so that so they had, like, both in English and in Hindi. These are general instructions, and then they had a list of these 30 recipes, out of which they could choose any 4, along with the free foods. And this was our study when we did a randomized controlled trial of our modified Atkins diet. So we had one diet group and one control group, which participated with just continuing anti-seizure medications. And ultimately, we found the results just as good as the randomized control trial of the ketogenic diet. And it was pretty effective in severe epilepsy syndromes like Lennox-Gastaut syndrome. And even though for younger children, infantile spasms, it is the ketogenic diet which is preferred, but we were finding it so much easier to do, explaining to the parents, and the counseling time was significantly reduced. We tried it for infantile spasms also, and it worked. We had 6 out of 15, 40% spasm freedom at 3 months. So, and then there were several studies. When I moved to Kalavati Saran Children's Hospital, we continued it in young children and found it to be a reasonably good, effective measure. And in fact, in our center, we practically only do modified Atkins diet. So we have done this study wherein we compared it with levetiracetam, because levetiracetam is a usual good add-on drug, usually second line, third line. So we compared it to that, and we found that it was more effective than levetiracetam. We have also done a whole randomized controlled trial of the Atkins diet for epileptic infantile spasms, which have not responded to the standard steroids, and found it was well tolerated and effective. We still have faced some problems. It still requires some weighing of foods, like the way we have designed it. It requires parents to be educated and motivated. It's very restrictive for vegetarians. It's problematic for older cognitively normal children. And there's no scope even in this for basic staples of Indian diet like chapati, rice, and pulses. So for the parents with low levels of literacy, what we decided that rather than making them weigh, we simplified it further, that we just provided them these measures and all the recipes were according to these measures. And this was actually an ICMR funded project wherein we simplified this diet and we found and evaluated in randomized control trial and found that it was definitely 50% of children had a better than 50% response in the 56% response to diet group versus 7.5% in the control group. How does this diet work? We don't really know fully, but what is understood is that developing brain actively uses ketone bodies as fuel. And when we use ketone bodies as fuel, it improves the brain energetics. And acetone is known to increase GABA levels, which is an inhibitory neurotransmitter. Acetone by itself has anticonvulsant properties. The diet increases brain PUFA levels, so it reduces the oxidative stress and it can release endogenous neuropeptides. And there's now a lot of work supporting its effect on gut microbiota, which I'm not going into for reasons of time. So some difficult populations, one is infants. So diet is difficult in this population, but highly effective and even well tolerated. So if we have formula, it's going to be much easier to do, but formula is difficult. So what we use is a mixture of a formula available, otherwise make endogenous ketogenic milk with soya milk and oil and add on in weaning foods, add on ketogenic foods. The other population, which is in the last 10 years, papers started coming up, is that the super-refractory status epilepticus and something called FIRES, which is fever-induced refractory epilepsy syndrome. So these are children, school-age children who previously children who develop after a febrile illness, really bad status, which just doesn't improve despite whatever is done, including multiple anti-seizure medications, coma-inducing medications. They just continue to seize. And what is found was that if the diet is started, then at least 20 to 90% showed improvement. So definitely diet has to be given. It was started, the studies shown that people usually waited and started after 13 days, but now it is recommended that definitely started much earlier and it's going to be very effective in this population. So the other good thing about the diet is that the benefits are not just seizure control. It has been shown to improve cognition, behavior, and sleep quality. So because it overall improves the brain's energetics, so definitely it's worth trying. And many times parents will continue the diet because of these positive effects, even though the seizures may not reduce or may continue the same. The other advantage is, of course, if we are able to bring down the anti-seizure medications or stop them, then also the cognition improves. So, okay, just a couple of new things on the way. One is try. Obviously, the diet is so much hard work. Is there an easier way of doing it? So there's some preliminary studies on triheptanoin, which is basically a medium chain triglyceride containing 7-carbon heptanoid. It's an edible, odorless, and tasteless oil. Is neuroprotective and anticonvulsant in several mouse seizure models. It works by something called anapyrosis, which is replenishing the tricarboxylic acid cycle metabolites. And some pilot studies have shown good effect. So some work on tailored diets as mouse models that they combine various things like medium chain fatty acids, PUFA, low glycemic index diet. And what is shown is that in mouse models, this kind of a diet was a non-ketogenic combination of different nutritional strategies, which not only reduced seizures, but also reduced the excitatory synaptic transmission and improved the histopathological markers of epileptogenicity in the temporal lobe. So to summarize, the ketogenic diets and its variants continue to be good options for refractory non-surgical epilepsy. So we can have flexibility in initiation, types of diets, and we have shown in numerous studies that it can be used even in low resource settings. We have different populations like infants, children with bad status, epileptic encephalopathies, and it has benefits like improved cognition, sleep quality, and the diets need to be tailored for age, indication, economic considerations, patient and family choice. I would like to thank all my mentors and co-investigators and the dietitians who worked in all these studies and all the patients and families who participated. Thank you.
Thank you so much, Dr. Suhasini. Anuja ma'am is already here. I think I would request her to say a few words about her experience with the dietary therapies in epilepsy.
I think Suhasini has compiled our 10 years of work in just a nutshell. it was too much of a hard work. And while we were, we both went together for the training to Dr. Nathan, and because at that time he used to take one doctor, one dietitian combination, and that was great because that way we had a very mutual understanding of each other. And her baby, she was the first one to start on working on there. Dr. Veena Kalpani pushed us to do that. Who's speaking? Yeah, somebody is saying you should start a certificate course. Definitely, Suhasini and myself are looking at it. But every module, when we plan a module, should be carefully planned. We had done one for the workshops, right? For the workshop, that was in a workshop mode. When we do a course with something, I think we will definitely think about it, and it has to be a good course where Dr. Nathan should be given a due respect for his, I think a lot of our pairs of doctor and dietitian pairs have gone out trained by him. So we will see how we sort of in a pan-India make a team and do this course. But yes, it had been a journey, and because what our main objective was that since ketogenic diet and Atkins diet is very difficult for the Indian population, we wanted to make it easier for our population, and that's how we did trials on low glycemic index diets also. In fact, there was a 3-arm trial on ketogenic diet, Atkins diet, and low glycemic index diet, and we found low glycemic index diet with a special calculation. It's not just a normal low glycemic index diet. There was a special calculation of protein, fats, and carbohydrates in that. And we found that although the outcomes were seen a little later in low glycemic index diet, but it was as efficacious as ketogenic diet and Atkins diet. So that was a win-win situation for our Indian population, that if we could do it, and we could also adjust a little bit of cereals in it for them, although very little amount, but they were satisfied that they could, and it looked quite like Indian diet, right, with all the modifications. So I think we are making headways. Our objective is to make more Indianized so that people can follow it easily, because at this time when the protocol is that ketogenic diet should go on for 3 years and then taper off and all, people are not able to continue it for 3 years, our Indian population. So it's very, very difficult. Right. So, yes, I know Suhasini does great work, and I think we look forward to work together in future also. Yeah.
Right. Nadia, would you like to add your experience with dietary therapies in epilepsy? And what are the...
I wish I could, Dr. Sweth. I wish I could. That's not my speciality, so I'm not going to offer anything in this. But I have to say it is highly specialist, and for us, it really is taken care of by our pediatric specialist departments and in the hospitals. Care is good, I have to say, it is good, but and we do have access. So listening to you was very interesting, and that projects, we're very lucky. The projects are available on the NHS, so patients can access them, which is, so it's, I have to say, probably you are more skilled because you have to manipulate the diet far more than we have to do. We can use products. So, and it's taken care of by our specialist hospitals with pediatric specialist dietitians. So no, I can't offer you anything more apart from that, you sound like you're more skilled than we are, for sure.
I have one question, Dr. Suhasini. Just because there are few complications that might be associated with modified Atkins or ketogenic diet, are there protocols for monitoring for those complications? For example, dyslipidemias, nutritional deficiencies. So, I mean, do we have to? Are there any specific intervals when we have to?
Yeah. There actually, because of lack of time, there is a whole international consensus guidelines published for this. And also for minimum guidelines for low resource settings, both are there, and I can share them. So baseline monitoring and what all is we monitored, like initially 3 months and then 6 months intervals. So there are full monitoring protocols.
Right. There were a few questions. One was by Kavya Chuk. I mean, she asked, should the pediatric population be on ketogenic diet for life? And I mean, what would be the right way to?
Only, I think if they have something like glucose transporter defect, then they have to be on it for life. But even in them, I think as they grow older, we can relax a bit and maybe move on to something less restrictive, like a modified Atkins diet or something. for life, it is not sustainable for life. I mean, even if 2 years, I consider it a huge success.
In
It's very
fact,
difficult.
even in inborn errors of metabolism, there are a few conditions where they have to be on ketogenic diet. We are still trying some other alternatives which is similar to ketogenic diet because people find it very difficult to be on ketogenic diet in India.
For the longer run, because it's not like what you eat in a family on the daily.
No.
Very, very difficult. Their whole social
very
life,
difficult.
their family life gets affected.
Right. Hiral Kapoor is concerned about the proteins unrestricted. It's written unrestricted, so won't it cause the kidney function?
Yeah, I mean, even though we say unrestricted, it never becomes that much unrestricted actually. When we, what we're trying to say is you don't restrict them, but usually you provide them as much as needed for growth. So it's not totally like you keep eating protein. Like, you can't feed kids that much protein anyway.
In fact, that's what Suhasini said. We have a little modified version of the ketogenic and the Atkins diet from the Western countries. Even in Atkins, it is a free hand where they are written free proteins in the Western, this thing. Here, we always tell them to weigh a little, even in Atkins, right? Because the proportion of protein to fat should be correct. They may take a lot of proteins which are not linked with too much of fat. Then the ketogenicity will not set in, and the patient will not show the outcomes. So we have to tell them that if you are taking a protein, it should be associated with enough fat also. Yeah.
Last one question from Manvi Gupta. She's asking if there are any organizations to support patients who are on ketogenic diet for epilepsy.
I don't know about patients, but doctors, Dr. Nathan has, I think, started something, but I think it's needed. But then, like in all other chronic conditions, support groups are not very easy in India. I guess the parents have their own challenges. It's very difficult for them to.
Right.
Imagine at home you have a child who cannot, walk, and every time they have to come to the hospital, as it is, they have so many challenges. So making a support group, we can make a support group and support them, but then people have to have time for that.
Right. Right. I think with this, I would like to thank you so much, Dr. Suhasini. It was a very comprehensive talk. You covered almost all the areas and gave us a beautiful, wonderful insight into how epilepsy management can be done with diet therapy. And it is comparable to a lot of anti-epileptic medicines. Right. Thank you so much, Dr. Suhasini. It's a pleasure
Thank
to
you,
have
Dr. Shweta.
I think with this, we move on to the last topic of our today's panel to discussion or of the meet. And this topic would be delivered by two speakers, Sean and Ms. Anuja Agarwala ma'am. So topic is regulation and structure of dietetic practice in UK, and Anuja ma'am would be talking about Indian regulation in nutrition. So I think we'll start with Sean. I think I'll just hand it over to you. We're running short of time.
Thank you. I'm just going to open up my slides now. Just bear with me.
And we have a picture of all three of us, Shweta.
Yeah, sure.
Unfortunately, it's not working. I think Naj is going to have to share them for me. It's not giving me an option to open up the slides now. Are you okay to share them, Naj?
1 second. Yeah. I'm going to share screen now. This.
Lovely. Okay, so I'm going to be talking to you today about statutory regulation in the UK. If you want to move on to the next slide, please. So I'm just going to give you a bit of an overview of what it is, the definition and the purpose of it. I'm going to talk a little bit about protected titles. I'm going to go through some of the standards that the Health and Care Professions Council, which is our regulator, the standards of proficiency that they set. I'm going to talk a little bit about when it goes wrong and fitness to practice, requirements for dietitians to maintain registration. And then I'm going to add a little bit more about annotation and some standards that can apply to people after qualifying and the future of regulation as well in the UK. Next slide, please, Naj. So for those of you on the call that aren't familiar with statutory regulation, the core to any decision to regulate a profession is really to determine the proportion of harm that they're able to do to the public in practicing in an unregulated way. So the real purpose of statutory regulation is about protecting the public from the risk of harm. And so statutory regulation refers to health and care professions that have to be registered in order to practice, and that's a legal requirement. Next slide, please. So employers in the UK are able to check that a person who has applied for the job that they're advertising of a regulated role, that they are a registered professional. So one of the first things that an employer will do when they're advertising for a dietitian or a physiotherapist will be to check the register and make sure they're a registered professional. So before they even look at their CV or their application, they'll do that first, and they'll fish out those that aren't registered because they're not eligible to apply for the role. And employers do have a responsibility to make sure that they're only employing registered professionals within roles that carry protected titles. So the registration with the professional regulator really does give that assurance to the public and to employers that the individual is fit to practice and that they have all the necessary knowledge and skills and experience to practice in the relevant profession. So there are many health and social care roles, such as practitioners, where actually it's not necessary for them to undergo full regulation. So the level of oversight would be disproportionate to the risk that profession proposes to the public. And therefore we have voluntary registers, and I'll talk about those in a little while. Next slide, please, Naj. So the Professional Standards Authority, previously known as the Council for Healthcare Regulatory Excellence, is the body that's required to oversee the regulators, and they cover 9 regulators that cover health and social care in the UK. So they scrutinise and oversee the work. They have a role to share good knowledge and practice between regulators, and often regulators will work together. So, for example, a recent discussion I had at a conference, someone from the General Medical Council went over to the HCPC to help them set up the education that they provide for international applicants coming over to the UK. So they do share best practice between themselves. The Professional Standards Authority will also conduct research, and they'll audit the fitness to practice processes that the regulator has in place to make sure that they're robust, they're fair, and they're being carried out according to their guidelines. And they do an annual performance review of each of the regulators. So they'll measure against their standards for good regulation, and they publish a report which is available online at the Professional Standards Authority website. They will flag up where there are concerns. So, for example, it was identified recently that HCPC weren't processing international applications in a quick enough time. And this was affecting both employers who wanted to employ these people and, of course, individuals who are waiting to have their applications processed. So the Professional Standards Authority have tasked the HCPC with increasing the time, reducing the time that they are taking to screen applications. The Professional Standards Authority also oversee accredited voluntary registers. So there are a number of people, as I said, working in these health and social care occupations where they're not subject to statutory regulation. There is a voluntary register scheme, and that allows people to decide they can choose to go onto these registers, but it really helps the public to know that they're going to be choosing a healthcare professional who's gone through some screening and scrutinisation before being allowed to practice. Next slide, please, Naj. So Fiona mentioned this in her talk, and I'm going to touch on it again, the use of protected titles within the UK. So if you are a regulated professional, your title is legally protected, which means others can't use it unless they too hold the same qualifications and registration. It is a legal offence to use the title unless you are registered. So you're also not allowed to purport yourselves to be a healthcare professional without the appropriate registration and regulation. So, for example, we had an example recently of someone who was calling themselves their name and then dietetics, and they were claiming to have gone through the dietetic training, but when you look on the register, they're not a registered professional. So they were giving the impression to the public that they were a dietitian, and that's one case that we might consider talking to the HCP about. We also have members contact us where they're concerned that someone might be purporting themselves to be a dietitian, and we generally empower members to themselves contact the HCPC with their concerns, and it's quite a straightforward process to report somebody if they do have concerns. Within the UK, we of course have practicing nutritionists and practicing dietitians, but the terms aren't interchangeable. So a dietitian can call themselves a nutritionist, that's fine, but a nutritionist couldn't use the term dietitian unless they held the appropriate registration. And we only have one regulator for dietitians, which is the Health and Care Professions Council. Next slide, please, Naj. So the Health and Care Professions Council is a big regulator, and they regulate 15 different health and care professions within the UK. The number of professions that they regulate has increased over the years, and they've lost a profession as well. So social care came onto the register and then actually decided to go off and set up their own regulatory body to meet their needs. They regulate around 340,000 people, and around 12,000 of those are dietitians. Next slide, please. So their main purpose is to set the standards. They set standards for education and training that people must go through in order to become a registered professional, and they set standards for practice, so standards that you must meet to allow you to practice in this profession. They also approve education programs, so you must complete an approved HCPC course in order to be able to join the register. So we would always encourage students to check that firstly the course is approved by the HCPC, and that it's also accredited by us, the British Dietetic Association, as the professional body. And we accredit courses as well, and we are busy. Our team is very busy doing that. We have a number of courses coming on board in the UK. A big function of the Professions Council is to keep a register of professionals known as registrants, and they are guaranteed to have met their standards. So the register is really easy to look up online, and you can put in the profession that you're looking for and the name of the professional, so you can double check that the person that you're going to be working with is registered. And the HCPC has a responsibility to take action if professions on the register don't meet the standards. So they really form the foundation for how they regulate. They clearly explain what they expect of registrants and also of the education and training programs that are available here in the UK. Next slide, please. The HCPC doesn't provide professional indemnity insurance, but they do explain that all HCPC registrants should have an appropriate professional indemnity arrangement in place, and that's a condition of registration with them. So we, as the professional body, part of being a member, entitles you to professional indemnity insurance so that you're covered to practice dietetics within the UK. And that's for both people working for the National Health Service and also in private practice as well. Next slide, please, Naj. So going now into the HCPC standards. So there are a number of standards, and I'll talk you through them. The first standards are around proficiency. So these are the standards that all registrants must meet in order to become registered and to remain on the register. So these are what we call the threshold or the entry-level standards that are necessary to protect the public. And they clearly set out the knowledge and abilities that a dietitian should have when they start practicing. Once you're on the register, you only need to be able to demonstrate that you meet the standards of proficiency that are relevant to your role. So we often get queries from dietitians who aren't working clinically, who might be in higher education, might have gone into management roles where they're not seeing patients, concerned that they won't meet the HCPC standards. And we can talk them through that and explain that actually it's just about making sure that you meet the standards relevant to your role and that you can clearly demonstrate and evidence that. Next slide, please, Naj. There are also then standards for dietitians already on the register around continuing professional development. So that's the way we continue to learn and develop throughout our careers so that we keep our skills and knowledge up to date and we continue to practice safely and effectively. And registrants are required to keep an up-to-date record and an accurate record of their CPD activities. We quite often refer to this as a portfolio. So each time we renew, and we have to renew our registration every 2 years, there's a process that we have to go through where we tick a box or sign to say that we are continuing to meet the standards and that we are continuing to develop professionally and maintaining our CPD. So each year that we renew, so there's a 2-yearly cycle, 2.5% of each profession are selected randomly to submit their portfolio to demonstrate that they're meeting the standards. And it's not a huge task. Often if you've kept your portfolio up to date, But it can be a little bit of a nerve-wracking time for dietitians. So again, if people are called up for audit, then we might have contact from members asking for a bit more support and guidance as to how to do that. And it's really around keeping your certificates, some reflective accounts, evidence to show that you have been updating yourself and maintaining your knowledge. Next slide, please, Naj. So the standards of conduct, performance and ethics really provide an ethical framework within which registrants must work. So these are very general. As I said at the beginning, the HCPC regulates 15 different professions. So they will set out general standards that apply to all of those professions across the board. So you can be sure of consistent conduct and ethical behaviours from registrants on the register. There are some more specific dietetic standards as well, and they break them down for each profession. So they outline within these standards what the public should expect from their healthcare professional, and it's really about having good character and good standing, and it's around things like respect, confidentiality and record keeping, just to name a few. There's quite a lot of these. These are the standards that are used if there is a concern about a registrant's practice. So it's these that they would be measured against during any fitness to practice investigation. Next slide, please, Naj. So as I said, the HCPC covers a number of different healthcare professions, so 15 in total. And so a lot of their standards are quite general and can be generic. So we have the BDA Code of Conduct, which applies another layer of expectations for our members and how they should behave and conduct themselves. So this applies to all BDA members. And as Fiona said previously, we do also have a dietetic support workforce who aren't a registered group of professionals, but would be bound by the Code of Conduct should they be a member of the British Dietetic Association. The Code of Conduct is also used for students as well. So when you sign up to a course, you would be familiarised with the BDA Code of Conduct, and we would expect all of our learners to be following the code as well. And whichever setting you're working or whatever role you're doing, the code would apply. So it does set out the high standards of behaviour that's required, and it gives a governance framework to ensure accountability so that we're working in the interest of public safety at all times. Members do have an obligation to adhere to the standards within the code, and that's made clear to them when they join the BDA. And it provides a set of principles so that they apply to the wider dietetic workforce, and it supports them to make informed choices. So when they are faced with ethical or professional dilemmas, they can refer to the code, and it should give them some guidance. And again, we do get people getting in contact, and we help them to interpret this if they're finding it more difficult. Next slide, please, Naj. So thinking now about when it goes wrong in practice and when there are fitness to practice concerns. So it's really important that all registrants have the skills and knowledge, but also the character and good health to practice their profession safely and effectively. So they must be what we call fit to practice. So this may involve issues of professional or clinical performance outside of the working environment as well. So we might see this where people may be behaving in a way that they doesn't fit with the standards in a sort of social settings, particularly if they undermine public confidence in the profession. And we're seeing cases of this at times on social media where we are questioning whether or not people are working within the standards. And again, they're designed to protect the public and also the profession as well, so not to bring the profession into disrepute. There will be different sanctions put in place if it's investigated by the HCPC. They may not be able to practice at all, or they may be limited in what they are able to do under the register. Next slide, please, Naj. So these are just some examples of the different cases where a fitness to practice is impaired, and it would be investigated under the following grounds. So it could be misconduct, so what behaviour that falls short of what can be expected of a professional person. And of course that can be what is professional could be discussed and interpreted differently. So there would be a panel that would investigate. It can be around lack of competence. So if we're seeing cases where people don't have the knowledge, the skill and poor judgment, and they're doing that repeatedly within their roles, if they're acting outside their scope of dietetic practice, then that would be something that might be flagged up to the HCPC. If they commit a criminal offence, certainly that would need to be reported to the HCPC, and they would need to consider whether or not that person was still deemed fit to practice. We do have people that apply for courses who have got previous cautions on their record. If I'm still right with the law, a caution doesn't actually come off your record, whereas a conviction does. And so then each person would be taken on a case-by-case basis, and there would be some investigation before they were accepted onto a dietetic course as to whether they were deemed an appropriate person to be able to undertake the course and become a registered healthcare professional. There's also been added around physical and mental health. So often with an unacknowledged condition, we do have a requirement that people who are on the register are looking after themselves. One of the standards is that you have to take care of your own health in order to be able to take care of others, particularly around mental health. So if people aren't seeking the appropriate treatment, getting the right support, potentially taking time off work when they need to, that could be something that's flagged up to the HCPC. Next slide, please, Naj. So I've just pulled a case study for you from the Health and Care Professionals Tribunal Service, just to give you a flavour of some of the things that come through to them. You can go onto this website and have a look at all the reasons that people are pulled up in front of the HCPC throughout the professions. Quite often record keeping is is commonly cited, and as well as not documenting things like BMI on a regular basis, using growth charts inappropriately, giving advice that falls outside of the scope of dietetic practice, giving advice that's not evidence-based. So this case study was someone who had concerns raised about relating to 6 different service users, and that was about failing to record sufficient details of dietetic assessments, failing to address the needs of the service user adequately, and failure to make necessary referrals within a reasonable time frame. And the panel on this occasion decided to impose a sanction which would protect the public, and it gave a 12-month suspension order. And during that time, they would need to be able to put things in place to demonstrate that they were once again safe and effective to practice. So I've put the link there to the tribunal service. It makes quite interesting reading. So it's worth having a look if you're interested. Next slide, please. So going back now to the HCPC standards, I mentioned before that they oversee education and training. So all of our education and training programs for dietetics in the UK are assessed by the HCPC and measured against the standards. We also accredit courses as the British Dietetic Association, and sometimes we will work closely together with the HCPC to ensure that courses are meeting the standards. So the HCPC will set the level of qualification that needs to be obtained to join the register. They will give some guidance on admissions, number of places that are able to be offered, requirements for candidates to be able to be admitted onto a course. They will look at the programme governance, and they'll also look at practice-based learning and type of assessments that are being used to assess students coming through the courses. So we actually, as the professional body, write the curriculum, and we also determine the placement hours, but the HCPC would take both of those into account when they're assessing courses alongside their own standards as well. Next slide, please, Naj. So a newer addition, although not very new, Naj has been dealing with supplementary prescribing for probably what feels like a lifetime, are standards around prescribing for dietitians. So once, as Fiona mentioned previously, dietitians are able to be supplementary prescribers, and Naj did a lot of that work to enable dietitians to obtain that status. So if you are a supplementary prescriber, if you've gone through the appropriate course, you are able to be annotated on the register. And again, that just gives colleagues and the public more faith and trust in that you are safe and able to practice in that way. So for those of you who don't know, supplementary prescribing is a voluntary partnership between a doctor and the supplementary prescriber to be able to prescribe within an agreed specific clinical management plan. We are lobbying at the moment for independent prescribing, which means we will be able to work and do this more independently. So the HCPC does set standards for education providers who deliver that training in prescribing. So you can be sure that anybody who has supplementary prescribing rights has been through an appropriate course and has had a similar level of education. So again, those standards really set out the knowledge and understanding and skills that registrant must have. And it's all about keeping people safe and making sure that everybody meets those threshold standards. For those of you that are interested, they use the competency framework for all prescribers, which is published and maintained by the Royal Pharmaceutical Society, and that's freely available online for you to have a look at. Next slide, please, Naj. So final slide, I'm just talking a little bit here about the future of regulation. So things are changing within the UK. Currently, our UK nurses are looking to get annotation on their own register, and they're with the Nursing and Midwifery Council to show that they've completed additional qualifications to be advanced clinical practitioners. And the HCPC are also investigating what this might look like for allied health professionals. It's a huge amount of work to get an annotation on the register. They have to be able to understand how practitioners might demonstrate that they've met the standards to be able to call themselves an advanced clinical practitioner. So that work is ongoing. And the HCPC standards are regularly updated, and we have had some standards launched more recently around things like communication, obtaining consent, and they're being updated again in September 24 this year. And they again will focus on things around person-centered care. Social media use is a big one for us, and I think people are concerned that currently we're not explicit enough as how we would want people to use social media. And of course, artificial intelligence use as well. So those standards are being updated, and we will then look at those standards and update our BDA code of conduct accordingly. And that's due to be updated by the end of 2024. So that's me. Thank you very much.
Thank you so much, Sean, for sharing such a wonderful structure that you have. And I think Anuja ma'am would be able to share what are the Indian regulations and what is the Indian structure, and what is the future for the.
So they are very, very structured. You know, we are just getting onto that structural mode. So I'll present where we are just now. So let me share my slides. So can you see my slides?
Yes, we can see.
Yeah, so I'm not putting it into a full screen mode because I'm scared off. Okay. So what are the dietary practice regulations in India? And at the not getting it there. Okay. So I have referred to what I'm going to present are some of the excerpts from the audit that we did, you know, in collaboration with the American Dietetic Association, United States, and it has been published. So this gives an overall view that what we are, where we are today, and where we are heading. And this audit had been really useful to identify the gaps and where we need a strong working team to set the standards right. Why isn't it scrolling? Okay. So as like Health and Care Professional Council in UK, we have actually have Allied Healthcare Professional Council, which has been passed through the Parliament Act in 2021, and it started working through the committees, and they have taken the committees in a central committee that started working in 2022. So HPC is an independent, what I understand is an independent autonomous regulator of the individuals. It has 16 health, psychological, and social work professions under it. And it keeps a health register, as she's rightly said, and keep the standards of training, professional skill, behavior, and health. And they keep in check all the standards from time to time. And they also have credit-based CPDs. In 2021, the Government of India passed National Commission for Allied and Healthcare Professions Bill by the Act of Parliament. It aims at standardization of prerequisite curriculum, training, skills, qualifications supported by experiential learning and certification. And it has about 52 cadres of healthcare professions in India. The work has just started. For us in India, the Government of India regulates everything. So even if Indian Dietetic Association has a competency package and we work on the standards, still to validate those standards, the Government of India has to approve it. So only then it will be validated. And you will realize why I'm saying it in the future slides. So we do have a dietitian and nutritionist database. Government of India recognized IDA as a biggest national organization to take the lead, and we are recognized not only by Government of India, but across all the dietetic associations of the world as one single association of India, which is exclusively for dietitians and nutritionists, and the most reliable data of dietitians and nutritionists, which we have. We represent not only dietitians, we also represent in Indian Dietetic Association, the academicians who are teaching in the various colleges, nutrition colleges, and it is widely connected with government agencies and professional organizations. Roughly, we have 17,000 live members pan-India. It is estimated to be only 1/4 of the data of the country, because it is really not mandatory for anybody to get registered in IDA. First, it is not mandatory. Secondly, even the dietitians who pass out may not think it is necessary to get the membership of Indian Dietetic Association. Not all the memberships of IDA. It is a non-profit, non-government organization. That is why it is not mandatory. And because it is supposed to be a private organization, which is non-profit, and unless it is all the database is taken on by the Government of India and approved, people will not think it is mandatory to get memberships and get identified in Indian Dietetic Association. And that's why we are at just the tip of the iceberg. Standards from theory to practice are very, very heterogeneous. We need standardization of the prerequisite curriculums, training skills, which is supported by, anyway, IHP aims to do all this in a sequential, structured manner. So how did we in Indian Dietetic Association are self-regulatory, and we strive to achieve excellence in working together as a team, and also regulate our members who are already there in our society. So how does the evolution of a dietetic profession in India? We got registered in 1962 with a few dietetic professionals, and IDA life membership category was organized at that time based on academic degree of medical doctors who were interested in nutrition. And members recognized that group of people as dietetic professionals. In 1981, we introduced the honorary registered dietitian status for the dietitian based on the academic qualification, food and nutrition degrees, and experience in the multidisciplinary hospitals and teaching clinical nutritionists. And they were allowed to use RD credentials issued by the Indian Dietetic Association and RD Board of Indian Dietetic Association. In 1995, RD credentials were created based on the examination. We started conducting the examination in addition to the academic and experience requirements. So the list of approved hospitals for internship was published and academic syllabus was created. In 2009, we introduced a train the trainer workshop conducted for educators on a newly developed competency package. By 2012, academic requirements changed to the eligibility was changed. Previously, it was dietetic professionals who have passed graduate degrees and any doctors who were interested in nutrition. But in 2012, we changed the academic requirements to any graduate with a degree in food and nutrition and dietetics, but 1 or 2 years of postgraduate degree, and requirements introduced for dietetic trainers for internship. So alternate non-internship experience route was added, 2 years of experience in a multidisciplinary hospitals. In 2016, 6 months continuous internship requirement was added. Revised competency package to add research, 50 case studies were required to be submitted before they get the RD status. 2018, non-internship multidisciplinary experience route increased to 5 years. So anybody who has not done an internship, they needed at least 5 years of experience to appear for the RD board exam. In 2020, in response to COVID, a virtual program was offered to the students for their orientation and case studies and refresher course, and train the trainer workshops were conducted. We increased the number of examination centers to 7. So the current norms currently to be eligible for the RD the professional can gain required experience through one or the two pathways, either a formal internship for 6 months or in a multidisciplinary hospital, or 5 years of employment in a multi-specialty hospital. So according to the audit, by 2021, 901 individuals have been awarded RD credentials from RD Board of India. The average examination pass rate is 10 to 15%, which is estimated 10,000 to 15,000 dietitians are RDA members. They are both RDs and life members. An estimated 10,000 dietitians have submitted documentations and have been approved as IDA life members. But how many are still practicing as a dietitians is still unknown. There are a large chunk of dietitians who are practicing as dietitians but not registered under Indian Dietetic Association or have got any RD status. So curriculum. University developed their own curricula for awarding food and nutrition academic degrees within University Grant Commission guidelines. IDA also post-recommended curriculum subjects necessary to meet the requirements to take RD board exams, and accordingly, they are trained in the colleges or taught the subjects accordingly in the colleges as well. However, curricula lead to food and nutrition degrees in India too heterogeneous. Even the courses names are very, very heterogeneous. Somewhere it is called home science degree, somewhere it is called a diet and nutrition or clinical nutrition. So there are all kinds of terminologies used for the course. Universities are increasingly offering master programs focusing on specifically on clinical nutrition or clinical dietetics, but still not very too much in numbers. Only a few colleges are offering the clinical dietetics courses. And still it is very heterogeneous in nature. So what we need to change the attitude and practices in India, IDA is recognized as a professional association for both RDs and non-RDs in India. Many other dietitians are also employed and practicing in India, but number is really unknown. There is currently no legal or universally accepted definition of skills, competencies, educational requirements for non-RD practitioners in India. So they continue to practice. Clients and the healthcare organizations that employ dietitians have no assurance that the practitioners who are not IDA Life members are qualified to provide services they currently deliver. Life memberships of IDA, RD credentials, and competency benchmark through RD board, academic enhancements through course credits are not essential to be employed in private as well as public sector hospitals. So you may have a competency package. We may have a competency package. We are taking our students. The colleges are motivating students to take RD board exams. They are RD credentials. If they pass, they are using RD credentials, but it is really not necessary to get employed in the hospitals. So, and also you can see the terminologies are not clearly defined. All these terminologies are used synonymously, like dietitians may call themselves nutritionists or vice versa. Clinical dietitians, clinical nutritionists, dietitians and nutritionists, medical nutrition therapists, personal diet specialists, food managers, nutritionist, and dietitian. That is a terminology given ICDA, but it is not going to work in India. So we are thinking about it. Although we took it, we approved it, but it is very difficult to get approved. We may approve in IDA, but it has to be approved by the Government of India. Prefixes and suffixes for all these terminologies are, they can use any prefixes and consultant, experts, coach, anything, but they're all synonymous. They're all doing similar kind of work and overlapping. So status of dietitians in India today. Few data are currently available about dietetic practices in India other than registration examination results. Despite the continued evolution of requirement designed to create a common skill, baseline knowledge for dietitian, heterogeneous still exist in educational preparation of dietitian across India. The core curriculum varies considerably between educational programs and institutions. Huge task to regulate, homogenize, harmonize curriculum to practice and create a robust database of dietetic fraternity in India. Need to work closely with Allied Healthcare Professional Council, and being the members in the council need to dialogue with IDA. So I think from 2022, we hear there's some kind of a work going on here, allied healthcare professionals, but there's not been much dialogue from their side from Indian, although Indian Dietetic Association is recognized by the Allied Healthcare Professional Council, but there's not too much of a dialogue at this moment. So we are looking forward and we are writing letters, we are representing so that they invite all the stakeholders from the dietitians group to have a dialogue and then proceed forward to have a universal curriculum or standardized practice in India. Thank you so much.
Thank you so much, Anuja ma'am, for sharing the challenges that we are facing in the nutrition in India. There is a question actually by Ms. Kavya Chugh. She's asking, when can we expect establishment of scope of practice for dietitians? I think you'll be able, you are the only person who can answer this.
So I think, Kavya, we all need to work together. First of all, as I said, there are 1/4 of the dietitians who register. Each one of us should motivate each and every dietitian to get registered in Indian Dietetic Association. After all, we are recognized as the largest body of India in the whole world, as well as Allied Health Profession Council. They also feel this is the only body which is exclusively for dietitians. So at least the first step is that everyone getting out of the college should get registered. Being a life member, you can be a graduate to be a life member. So there's nothing wrong in being a life member of IDA. At least you come to know what is the updated things that we are doing, how we are, interfacing with the government of India. From time to time, we update our members. And for RD board exam, you also come to know what are the competency. Let me tell you, the competency package which RD board has formulated is really very strict. People are getting out of the college, they still need some, some insights into what is going to be asked in RD board examination. They fail a lot of times in RD board examination. So that's why they've started the initiative Ujjwal. It's been started by RD board, which goes on for 3 months for online course for the dietitians who are appearing for RD board. So it is a very comprehensive course that they need to do with RD board, so that they train them and gear them towards, so that, they while appearing for the RD board, they know how to answer questions and what they expect out of them. So I think it is, the onus lies on all of us. You can expect the establishment of scope, but everybody has to come together and do that. As Charu has very finely presented what should be the criteria, then let me tell you, we are even from state to state, we are so different. Our salary structures from state to state is so different. Our courses from state to state there's so much of diversity in India. There's so much of different setups in India. We need to first study that, and then only we can tell you the scope. It cannot be just one benchmark for all the dietitians in India. It is a different kind of a country. And to come to the level of UK, it will take us several years.
Right. I think, but you're taking the steps in the right direction, ma'am. I think it's going to be slow, but
it's definitely very well established. But let me tell you, even in most public hospitals and premier hospitals, they do not consider RD. They said, what are we have to do with RD credential? Government of India doesn't ask for it. So that is a status. While in other Western countries, whether it is America or Britain, they have their strong hold as an association. And they are the ones who decide the curriculum and everything. It is not to be approved. Am I right, Nazia, if I'm saying that?
Yeah, absolutely, there is. And I would say, actually, just to add to that, is that even in the UK, the dietitians, compared to, our number is small compared to even other healthcare professions. I mean, physiotherapy is three times the size of us. So what we do is look to move together. So we move together as a block, as AHPs, as one thing, but also a lot of the noise is created by our medical professionals, who have a lot of a bigger voice, whether we like it or not. So doctors saying, I want my dietitian to be regulated. I want my dietitian to have these skills. I want to have trained dietitians on X, adds value. It does add value. So just as Anuja can do what she can do, she's got a huge task to do with what we call probably a small profession, So even for India, I would say if the doctors believe in dietetics, if they believe in nutrition, you could do a lot by supporting this, by supporting the government to say, we need our dietitians to be regulated. You need to push forward because there's a lot of people giving out advice and making matters worse. So I would say just that is that, you know, the more that the whole healthcare professions can get together and regulate at least, you know, the ones that really will make a difference to your populations, come together because there's power in that. And you can make a difference with government. They will move because they're being asked to.
Right.
So patients need to ask for it, and doctors and all the other healthcare professions need to ask for strong regulation.
Yeah.
It's not an easy thing. Sorry, I'm saying it like it's easy. It's not easy. But I'm saying something, you know, join together. If there's anything that the medical profession can do to support it, is that.
Yeah.
Speak
So
up.
the moment we start doing and documenting things, not in the same ideal manner as Charu has said, maybe it is not possible. But if we take baby steps in documenting things, definitely your doctors will also understand that this is so very important and so very different what we are thinking. It is not just giving a diet chart to somebody. It is so much deeper than that. So I think the onus also lies on us to make them believe in us and do a good work. You know?
Yeah, absolutely.
And
It's
think-
mutual respect. Absolutely.
Right. I think with the advent of artificial intelligence, the things have already, you know, becoming smoother. So
Started
you
to
take
move.
less time to do a task. So for example, if you have to work like fill a form, a lot of things would be like drop in.
Populated.
I mean, softwares can be created. So if we become a little bit of tech friendly, I personally feel, we'll be able to shorten the time, document more, create more database. So, and that I think would bring more of the healthcare professionals, including the doctor and nutritionist, working together. And I think medical professionals are also realizing the you know, importance of nutrition as the day passes.
Absolutely.
So
They have enough to do. Doctors have enough to do without having to do the diet as well. So, you know, let everybody do what they're best at. Absolutely.
there has to be
Exactly.
synergy.
Yeah.
So,
Work together. Yeah, for sure.
I think it was a beautiful, you know, session through the first day of the symposium. It was a beautiful talks were there, comprehensive. We discussed a lot of issues, the regulations, the structures, when the structure is needed and when the structure is not, has to be, you know, surpassed. For example, if, for example, there are different types of diabetes, different requirements when it has to be personalized also, and what are the regulations. It was a very fruitful discussion through the first day of symposium. And
I think it's a total success. What do you think, Nadia?
Yeah, no, really enjoyed it listening to you. Really, honestly, I'm humbled by your clinical knowledge. Absolutely.
Thank you so much. But we all have to learn from each other. And I still think I'm retired from All India Institute of Medical Science. I still feel I have so much to learn. So I keep doing things my bit, right?
I thank all the attendees for coming today and joining us for discussion and for asking various questions. There are a few questions that I would mail to Nadia on the email and reply to Angel and Jyoti on your email. And
sure.
I think today we should conclude for the day, and looking forward to tomorrow again and for the, you know, next round of talks. And again, a very good night to all of you from India. I think it's
good night. For us, it is. Thank you so much.
Thank you. Thank you for joining.
Bye.
Bye.